Ένα, δύο, μ' ακούτε, ένα, δύο. Ένα, δύο, μ' ακούτε, ένα, δύο. Ακούγομαι, ωραία. Μην κλείσετε τον ήχο ένα λεπτό. Γιάννη.
Good morning, everyone. Thank you for being here today. Dear Rector of the Cyprus University of Technology, dear members of the Parliament's Health Committee, dear honored guests, ladies and gentlemen. A very good morning to everyone, and thank you all for being here today. We would like to welcome everyone on our today's seminar on the topic of vaccination acceptance, the safest project, which is organized by the Cyprus Technology of University, the University of Cyprus and the Cyprus Medical Association. To kick off this morning's greetings, I would like to welcome Dr. Angelos Kassianos, lecturer in health psychology at the Nursing Department of Cyprus University Technology and the research coordinator of the Safest Project, to deliver the opening speech. Thank you, Dr. Kassianos. The floor is yours.
Good morning, everyone. Dear Rector of the Cyprus University of Technology, Professor Panagiotis Zafiris, dear member of the Parliament's Health Committee, Marina Nicolaou, dear esteemed guests, ladies and gentlemen, please let me welcome you to today's seminar, the Safest Project Seminar. I think we all understand the importance of the topic, so it becomes even more obvious how much we need the scientific evidence in terms of promoting the vaccination campaigns and the vaccination programs. I was actually listening last night to the news, and I was shocked to see how much there was increase in cases, and also the vaccinations became stable. So I think thinking about that, we have left behind the vaccination programs. It's not correct. But let me also specify that today we're not going to talk only about COVID-19 vaccination. So the main aim of the Safest Project is to understand a little better how better can we promote the pediatric vaccinations, because this is also very, very important, and sometimes we forget about that. So the Safest Project started around 2 years ago. We tried to understand what we call the social contagion of vaccination attitudes, beliefs, and behaviors. So how can, to put it simply, how can one person influence another in different forms of networks on terms of vaccination attitudes? And we have been doing a really amazing work the last 2 years, and we're very glad today to be sharing with you the scientific evidence. Another aim of today's seminar also is to initiate a discussion. And for this purpose, we have very esteemed guests. So, for example, Dr. Miguel Arriaga from Portugal will be talking to us about the experience of his division in working with the Portugal government during the COVID-19 pandemic in terms of promoting the vaccination program. And we also have another colleague from Germany, Dr. Matthias Geiger, who will be talking about a very important framework and theory. We call it the 7C model, in terms of understanding what are the determinants of vaccination acceptance. So we're very excited about this. We also hope that all of this knowledge that we gather today, all of this discussion, will be translated into policymaking, because this is the final aim of any type of research. Doing research just for the sake of research is just half of the journey. We need to promote our evidence into those who take the decisions in order to benefit the quality of life of the population. Finally, from me, I want to say a big thank you to all of you for attending the seminar today, here and online. And a very big thank you to the organizational committee of the Safest Seminar, because none of this will happen without their effort. And I would like to thank Dr. Nikos Middleton, Dr. Christiana Nicolaou, Dr. Urania Kolokotroni, Ms. Pinelopi Konstantinou, Dr. Maria Kyprianidou, Dr. Andrea Christodoulou, and Ms. Christiana Karashali, among others that have been working all these weeks for months, actually, for making this seminar a reality. And also, I'd like to thank all the technical support that we have today. So enjoy the rest of the seminar. I hope it's very useful and very fruitful. Thank you.
Thank you, Dr. Kassiane. Proceeding on, I would like to call Professor Panagiotis Zafiris, Director of the Cyprus University of Technology, for his greeting speech. Professor Zafiris, the stage is yours.
I didn't prepare anything, but Kalimera, good morning to everybody. It's a pleasure to be here because not only I think this is a hot topic and of a very important interest to the professions, but also it's an important topic for us because of what I will be describing later, related to the experience we had handling these issues last year. I think despite what Angelos said about the COVID period not being the focus of this conference, I will take a few minutes to focus on that, and then I think the rest of you can discuss the more important topics related to the nursing discipline. The university unexpectedly ended up being the focus of this debate of vaccinations last year. The decisions we made the university the focus of discussion and debate around whether we should make vaccination compulsory or not in such difficult situations. For those who are not familiar with our decision last year was to allow access to the physical lecturing only to students and staff that are vaccinated and allow remote access to everybody who has not been vaccinated. This was, for those who are not familiar with the Cyprus situation, this was we were the only organization that made such a decision at the level of education, but also in all other governmental and semi-governmental entities. We made the decision based on specific suggestions from the health school and also based on the situation regarding our structure as a university, city university. We have 40 different buildings distributed in the center of a living city. Our students are around 4,000 students, and they live and operate, act in this city center. So the threat of spreading the COVID epidemic at that point was not just within our own student community, but within the whole community of Limassol. We thought that was an important issue to take into account. I will be very brief by identifying what were the challenges and whether I was asked actually yesterday at an interview whether we regret making that decision. Because the challenges, what was the outcome? The outcome was that the university's decision became the focus and have been criticized by a large number of the vocal community against vaccinations at that point in time, but they have been considered as wise decisions by another large proportion of the population, and definitely by the scientific community. We had been, at that period, I had phone calls from Pitropos Prosopikos Dedemenon, the Commissioner for Personal Data, requesting that we should not be collecting data from any member of the community, but we should make physical checks regarding their vaccination or their safe pass status. That was practically impossible. It would have required the whole administration services of the university to just do checks. Then we had two protests, around 30 students each time. I have had email attacks about my physical presence, have been threatened that I would be exhausted. I have been receiving in the university lots of complaints and threats in the social media. We have been asked to attend the Parliamentary Committee of Education to explain why we decided to do this. We have been called that we block there are other voices to be heard. We had one legal challenge in the court about our decision. We won the case, but following that, we have active now 2 legal cases against the university regarding our decision then. We have a report by the Commissioner of Personal Anthropinών Δικαιωμάτων on Human Rights that we have done everything wrong. We explained to her the situation and she has corrected her statements. We had taken a decision that was based on scientific data, but that has been challenged. And I think that leading to the event today, it's important to note that this information that we need to discuss today is primarily on the subject of how we communicate and handle these issues better. Did we make mistakes in the past regarding this decision we made and regarding the handling of it? I think the decision was wise. And I stated it in a very simple way yesterday in the interview. If with our decision we managed to save even one life, anything we have done through the past is worth every attack we had. It's that simple. But then, did we handle the situation right? I think we did our best under the circumstances, but definitely communicating our decision to the students and staff and to the community could have been done better. But could it have been done better then at that point of time? I'm not sure. Thank you very much.
Thank you, Professor Zafiris, for your greetings. Moving on, we would like to project a pre-recorded greeting of Cyprus Medical Association by Dr. Petros Agapangelou.
Distinguished keynote speakers, exceptional professors and colleagues, ladies and gentlemen. The Cyprus Medical Association is proud to organize, along with the Cyprus University of Technology and the University of Cyprus, the seminar Vaccination Acceptance, the safest project. This is an excellent initiative if we consider as an important additional factor the COVID-19 experience over the last 3 years. Indicators have shown that COVID-19 vaccine acceptance is associated with vaccine hesitancy, perceived risk, previous vaccination experiences, factors which public health authorities should consider. Starting in early 2020, the COVID-19 pandemic has been responsible worldwide for millions of deaths and patients with long COVID syndrome. In an attempt to stop the spread of the virus, the blanket administration of COVID-19 vaccines proved to be the most effective measure. Yet, the existence and availability of functional vaccines did not and still do not ensure the willingness and intent of people to be vaccinated. By using responsible methods of communication in order to pass the correct message, to deliver the correct message, I believe we can overcome any barriers to vaccine acceptance in the community. I'd once again like to congratulate Cyprus University of Technology and the University of Cyprus for organizing this seminar. Please note that the Cyprus Medical Association empowers the scientific exchange of knowledge. CIMA is not simply a professional body. but it also contributes in various other ways for the benefit of the patients and of the society. In addition, it attaches particularly importance to the scientific, social, as well as cultural dimension by organizing scientific world conferences and one-day workshops, events, lectures, and webinars. Our common aim is to evolve the health framework, evolve ourselves, and promote the necessary initiatives to protect public health. So let me conclude by thanking you all and wish the best of success. I'm certain that a fruitful dialogue will develop and the message will be delivered as the scope of the scheduled seminar. Thank you for your attention.
Μαθαίνοντάς μου να απευθύνω εκ μέρους του χαιρετισμό και ευχές επιτυχίας. Επιτρέψτε μου αρχικά να αναφέρω αυτά που δήλωσε η τέος πρόεδρος του ICN, Άνετ Κέννεντι. Η πανδημία αποκάλυψε πόσο εύθραυστη είναι η ανθρώπινη ζωή, καθώς και τη στενή σχέση μεταξύ της υγείας, του πλούτου και της ευημερίας. Έχει δείξει επίσης την αδυναμία πολλών συστημάτων υγείας, τα οποία θα ενισχυθούν σε μεγάλο βαθμό εάν οι κυβερνήσεις λάβουν επίγουσα δράση για να αντιμετωπίσουν την τρέχουσα παγκόσμια έλλειψη 6 εκατομμυρίων νοσηλευτών. Η πανδημία ως αποτέλεσμα του κορονοϊού SARS-CoV-2 ανάγκασε τους νοσηλευτές και τις ΜΕΕΣ να εργαστούν κάτω από μεγάλη σωματική και ψυχολογική πίεση, ειδικά σε περιπτώσεις όπου η έλλειψη κατάλληλου ατομικού προστατευτικού εξοπλισμού πρόσθεται φόβο στα εξουθενωτικά συναισθήματα που αντιμετώπιζαν. Οι άνθρωποι που έχουν αναρρώσει από COVID-19 είναι πρόεδροι χωρών, είτε είναι πρωθυπουργοί, είτε απλοί άνθρωποι, δεν θα ξεχάσουν. Και για όσους έχουν πεθάνει, μια νοσηλεύτρια μπορεί να ήταν η τελευταία φωνή που άκουσε, το τελευταίο χέρι που άγγιξε, το τελευταίο πρόσωπο που είδε. Όταν ο ιός μας διέψευσε για όλα όσα σχεδόν θεωρούσαμε δεδομένα, εμείς δείξαμε τι είναι πιο σημαντικό για όλους μας. Η ζωή, ο άνθρωπος και αυτοί που αγαπάμε. Ο Πασίμ στάθηκε αρρωγός και συμπαραστάτης στις προσπάθειες της πολιτείας για αντιμετώπιση της κατάστασης με θελοντική προσφορά και αγορά εξοπλισμού ατομικής προστασίας για τις έκτακτες ανάγκες που είχαν προκύψει στα αρχικά στάδια της πανδημίας. Συνεργάστηκε με το Υπουργείο Υγείας στο θέμα εμβολιασμού των μελών του και ενθάρρυνε τα μέλη του να εμβολιαστούν, αλλά και να εργαστούν εθελοντικά στελεχώνοντας στην πρώτη φάση τα κέντρα εμβολιασμού. Είμαστε ιδιαίτερα περήφανοι για τον τρόπο με τον οποίο τα μέλη μας, νοσηλευτές, ΜΕΕΣ και επισκέπτριες υγείας, εξακολουθούν να αντιμετωπίζουν τις δύσκολες ώρες που περνά ο τόπος μας. Είμαστε ευγνώμονες για τις αυτοθυσίες τους, αλλά και το γεγονός ότι πάντα κύριο μέλημά τους παραμένει το καθήκον προς τον άνθρωπο και η υγεία των πολιτών. Ευχαριστώ το τμήμα νοσηλευτικής του ΔΕΠΑΚ για τη μέχρι σήμερα συνεργασία με το Διοικητικό Συμβούλιο του ΠΑΣΥΝ. Εύχομαι καλή επιτυχία στην ημερίδα σας και προσβλέπω στη συζήτηση στρογγυλής τράπεζας σήμερα το απόγευμα. Σας ευχαριστώ.
Thank you, Dr. Fella. Now we'll proceed to the greetings that will be given by Mrs. Penelope Constantinou, representative of the Cyprus Psychologists Association. Mrs. Constantinou, the floor is yours.
Esteemed guests, dear colleagues and students, dear audience, it is with great pleasure that we extend a welcome to the Safest Project seminar on vaccination acceptance. Projects like this, in helping us gain better understanding of what went wrong, were in dealing with public health issues like the pandemic, and in better preparing for similar future events by developing prevention plans, policy, guidelines, and structures that deal with these matters. As a psychologists association, from the beginning of the pandemic, we had been involved in various talks, webinars, and efforts to educate the public about how to deal with the uncertainty, how and why people choose to comply or not with the measures, how parents can help their children cope, and so much more. The Safest Project, and in particular today's seminar, address one of the more sensitive issues and bigger challenges that we have had to deal with during the pandemic these past 3 years. Throughout the pandemic, fighting misinformation and conspiracy theories presented as a hurdle for all of us working in the health sector. In addition, challenging commonly held beliefs and attitudes about health or illness was also a huge task, especially in a society like Cyprus, where a lot of the times these things are based on word-of-mouth information or knowing someone who knows someone, where their validity is not questioned, or a single person's experience is used to extrapolate and overgeneralize to the entire population. Of course, other factors contributed also to such mistrust to measure, including vaccination. From today's program, we can see that several of these factors will be addressed, including one of the most important ones, how governments appropriately and consistently utilize scientific knowledge and expertise to address issues to public health effectively. Moreover, the role of media should not be undermined in developing preparedness. As Cyprus Psychologists Association, we are committed to continuing our work for the benefit of society. We would like to congratulate the Safest Project team for their initiative and interest in supporting and developing the public health sector and wish them every success in the endeavor. Dr. Elaine, on behalf of Dr. Elaine Karayani, Cyprus Psychologists Association President.
Thank you, Mrs. Constantinou. Thank you all again for your great speeches. Let's move on to the next sessions of our seminar. I would like now to call on stage the chair of this session, Dr. Nikos Mitleton, Associate Professor in Health Sciences Research Methodology and Biostatistics at the Department of Nursing and Cyprus University of Technology. Dr. Mitleton, the floor is yours.
Hi, everyone. You're going to see me moving a lot from here to there. I would like to welcome everyone. Thank you for being here today. Thanks to our guests and invited speakers. Thanks to all the speakers for their welcoming address. For this next session, we thought of doing something interactive. So before moving on to the main part of the seminar, before we start hearing about theoretical models and frameworks and research evidence, we would like to do a quick mapping of our perceptions of what influences vaccine acceptance. I will be giving you instructions as we go along, but I would like you to get your mobile phones out for this. For anyone who hasn't got mobile data to participate, we would like everybody to participate. I'm not telling you yet exactly how and what for, but because we only have 15 minutes for this session, I will be giving instructions as we go along. Okay, so either use your own mobile data or connect to the CUT Wi-Fi. I know we have limited time, but before I move on, I'm going to go off script and thank the rector of the university for his honesty. The university had to take difficult decisions, but necessary decisions. And it seems that so many months forward, it's still a traumatic event for everybody, but a necessary traumatic event because at least we put the topic into the public debate and into the public discussion as a university. I also want to address Dr. Falaf from the Nurses Association and say that we were recently, a lot of us, many colleagues, we were at the European Public Health Association, and what you just said, that having one more nurse might make the difference is actually backed up by scientific evidence. And the CMOR consortium, led by the University of Nicosia, and we have some colleagues here from this consortium, have found evidence from an international study that excess mortality during the first wave of the pandemic, one of the main factors that determined excess mortality was the number of nurses. And that was to treat people with COVID, but also to look after everybody else, the chronic patients who the systems just deserted at the start of the pandemic. Thank you very much. Right, let's move on. Okay, I'm going to stay here. I hope technology doesn't fail us like with the sound. Before I pose my question to you, let's just do a quick check that it all works. We would like to have a quick profile of the audience. So please go to www.menti.com, use the code you see on your screen, and just tell us briefly who you are. You can choose up to 2 things. I'm an academic, but I'm also a parent. If it works, we should start seeing little dots popping up on the screen. If it doesn't work, then I have to improvise. Okay, kind of works. I'm going to give it some more time. We have more people in the audience. So far, 9 people participated. We can see it at the bottom corner. Again, you might have to give us some more time, because I think in 15 minutes, we're all very slow Saturday morning with our fingers, I think. Okay. How are we doing? Everybody okay? Everybody participated? The numbers say otherwise. We're more than 17 people in the room. And okay, I'll move on.
The students, what do they select the students?
Other. We should have some scientific and professional association members here too. Nobody selected that. But I'll move on, because this is not perfect science, right? And this was just to test the system. So I'll move on, and we still need your phones, and I guess you would have seen a different question popping up. This session is split into 2 phases. This is the first phase. As I said, we're going to try and map our own opinions and perceptions on a couple of questions related to vaccine readiness. And we will talk both about childhood vaccines first, and then about COVID. And we wanted to separate the 2. In terms of what will happen is that once we start participating, please don't participate yet until I give you some instructions. We will see words popping up, and we're going to have a cloud. In the second phase, a team of us will get this cloud and we'll try to work with it, do a not so perfect analysis to put it into some frameworks that have been used to describe vaccine readiness. You're going to learn all about it in the next session, but very briefly I'd say that vaccine readiness ranges from total refusal to acceptance, with a degree of hesitancy in the middle that we might all find ourselves somewhere for different vaccines at different stages of our lives under different circumstances. And we will have the honor to be joined by Dr. Mattis Geiger online to discuss our findings. So let me pose the first question. Let's focus on childhood vaccinations for a minute. I'll say some parents are hesitant towards routine children's vaccines. So towards their refusal or hesitant or delaying in vaccines or doing it but not sure whether they should have done. What are the main reasons, you think? And please pop one or two words or short phrases. The system should allow you up to 5 contributions. You might just contribute one word or take the opportunity to say as many things as you want. Please don't be reluctant in participating. And in a way, it's going to be very useful for us as well to see how well our perceptions match some of the frameworks that have been described in terms of what determines vaccine readiness. It's nice, I see things popping up. Some things become bigger. That means other people have suggested the same. All right. Let's give it some more time. I would like to see more people participating, and in fact, I will say, maybe it's not the time yet, we do want some things to start getting bigger. We're using a modified version of what we call the nominal group technique. This method is a way to assess people's perceptions about a topic independently of one another, because I don't see people collaborating with somebody next to them before they pop something in. This is your independent opinion and perception of what might describe this phenomenon. But it's also a technique that causes or builds consensus, because it goes in rounds. So let me say that you can participate again. So as many times as you want, and we would like it to participate again. Things up there that you agree with, whether you didn't think about it, you might have not thought about it in the first round, and then you see somebody else suggesting it, you might say, oh yes, that too. Please participate again and vote for it, nominate that factor, because then things will start getting bigger. I see side effects, I see fear, I see misinformation getting bigger. I hope they're not too small. I don't know if you can see them on your screen. I think you cannot see them, you can't see the cloud on your screen. So maybe I'll very quickly read some of the words to see if somebody didn't think of that and they want to add it. Religion, health literacy, other people's opinions, false information, similar to misinformation then, family background, no belief in science, Okay, the number is steady at 18. I don't see more participation, so I could move on if you think we're done. I do see some people still holding their phone, though. I hope you're enjoying this as much as I am. Okay. I'll wait for the rest of the team. Maria Christiana Pinelopi, what you say? We stop? Do we have enough for the second phase? Okay. Then I will stop and we will do the same. Again. But now I will pop up. Don't want to lose this. Okay. Hope it doesn't go away and I can download it because we need it. And now I want you to do the same. Perhaps it wasn't very easy for us to separate the issue of childhood vaccination and COVID vaccination. We're all coming out of the last 2 years and we're all thinking COVID. But I would like us to do it again. And now I would like us to think about COVID-19 vaccines. What are the reasons for hesitancy or refusal among some of our fellow citizens? So again, we're thinking at the bottom end of vaccine readiness. We all know that vaccination rates vary from country to country. Cyprus, it's not. Oh yes, it's a different code, sorry. Okay, how fast they were developed and produced, conspiracy, how much it was tested, health literacy, again, trust, political issues. Because we wanted this second exercise to be quick. I think we only allowed one participation. So please use your 5 words. Don't just write one and submit it immediately, because I think the system might not allow you to participate again. Of course, if we really, really want to add things, I can go back and change the setting. But... Okay, we're up to 11 voices. Okay, so it allows you, okay. We have 12 voices. We get social media, we get side effects. We get fear. We get anarchy. We have trust again in bigger fonts. I'll leave it for a bit longer. And by the way, I did a head count, and we are at least 30 people in the room. So some people are cheating and they're not participating. Okay, cheating was the wrong word. It's not about cheating. It's nice, though, when we're given the chance to participate and voice our opinion. There is no right and wrong answer here. This is about what we think influences this phenomenon. Nobody's going to tell you whether you put a right or wrong answer. And in fact, they're all right answers. And they all fit somewhere in the framework of what we know about vaccine readiness. We have the 18 out of the 30 people that participated in the first round. Okay, I'll wait for one more person. Angela, how are we doing with the program? Time up? Time's up for this part? Again, we can do the same. If we see something up there that we didn't think of, we didn't suggest, but somebody else did, and we agree with, please participate again and vote for it, nominate it. All right. Thank you very much for this. As I said, this was the first part. So we will go to a different room. We'll see what suggestions are there, and you'll see us again in about 2 hours from now. Thank you.
Thank you, Dr. Middleton, for this lovely mini experiment, mini survey. Moving on, I would like to welcome again Dr. Angelos Kassianos for the next session, with his being a chair.
Thank you, Andrea, and hello again from me. So it is a great pleasure for the next session of this seminar to be welcoming our main speaker. So it's a great honor having with us Dr. Miguel Arriaga. I will say a few words about Miguel, and then we will proceed with Miguel's presentation. So Miguel is the head of the Division of Literacy, Health and Well-being at the Directorate General for Health in Portugal since 2015. He's also a lecturer teaching and collaborating with other universities. He's working in different European joint actions with special focus on the areas of chronic diseases, promoting healthy aging across the life cycle, health inequalities and frailty, assuming in this last role the quality manager for the joint action. Miguel is also responsible for the development of several national health promotion and disease prevention campaigns with special focus on health literacy. He has worked in the scope of the National Program of Health Literacy and Integration of Care. Miguel is finally also working in the field of stress management, psychological first aid, psychosocial support in crisis and emergency situation. And let me say, it is a great honor and great pleasure having Miguel with us today in this seminar. And please, Miguel, let me ask you to take your seat.
Thank you so much. Thank you, everyone. Let me give my first words to our director, and thank you, the university, for the invitation. Of course, also to Professor Angelos, the invitation to be here. It is my honor to be sharing with you some of the ideas and some of the thoughts that we had in Portugal facing this pandemic, but also to give you some examples of what we do facing vaccination in our reality. I will try to be seated which is for me it's a big effort. We are not moving around, but I will try to do it anyway. But I will give you some words, and I believe that afterwards we can have some space to questions. So let's try to gain some time, and please feel free to make any question that you want or any comment that you feel needed. I'll be happy to answer you back. Okay, so starting from the beginning, I would like to give you an overview on the COVID vaccination and what have we done so far, talking about the governance and the operations, the evidence-based recommendations, the vaccination centers, as well as the National Vaccination Program, some final messages, and what have we done with the BCI, the Behavior and Cultural Insights, health literacy, and about this combination that we try to organize as much as possible during not only the pandemic, but also during all of the stages in what concerns with our national vaccination program that is more than 58 years old. So it's a long program, robust, and with very, very good results that I would like to share with you. So coming from the beginning, let me show you this was the most recent data that we have on the vaccination against COVID-19. And we know just in a short scale that 98% of all the adult population already completed the primary vaccination schedule. And 99% of the population, people over 65 years old and older, received the first booster. This tells us that the results are probably some of the best in the world. And I would like to tell you how did we do it and how did we reach this kind of data. This is the national data. This is quite clear. We have no objective in moving or picking up data that is not real because it's not good to anyone. Sometimes people can even question how are the results so good. And that's something that I would like to share with you, our experience, because this is not only related with COVID. Our vaccination rates are extremely high in Portugal. So until the age of 18, the vaccination rates are all around 98, 99%. Of course, we have some hard to reach population, sometimes the migrant population, but also some national population that is living in some specific areas. And those are the ones that we need to focus more to even improve. There are always space to improvement. And actually, we need all to be very aware of these new developments, and the vaccination on COVID-19 brought us different challenges that we didn't have so far. And all the questions about vaccines, all the information about vaccination, and I was hearing our director of the university talking, and we raised so many questions that now we had different challenges, how to explain, and probably to get to a point, how much is too much? When we talk about communicate, to provide information, because if you are gaining all the time and to providing all the time the same information, you are raising questions that were already observed. You are giving space for the anti-vaccination groups to be more aware and to pick up some information that probably is not the most correct or not explained in the most correct way. But this is the results that I would like to show you starting from the beginning. Of course, when we can see, like in the young stages, we are getting the results are not as good as the oldest one. But this was also because our bet was specifically in the most vulnerable population. So that's why our focus was specifically for the elderly or for people with specific diseases. And this is also why is it important to get vaccinated. And this is something that we explain, of course, to all the population, providing them with this information, of course, not only with graphics, but to providing them information in a clear way. So these lines that you can see here, I think that we can see like the arrow on the screen. Probably not. But these lines that you can see here are the lines that tell us when we start to have more than half of the population coverage, in this case with more than 80 years old, and the impacts on hospitalization and the impacts on mortality. And you can see, even though we have a decrease in the text of new cases on COVID-19, the vaccination showed us like a tremendous impact on hospitalization and in lethality, in mortality, which is something so obvious to everyone that the results are absolutely amazing. So that gives us also a new boost, a new communication boost, or a new communication opportunity to increase our vaccination rates and to tell people that was extremely important to do it. But, and this is something that I would like to tell you afterwards, we needed not only to organize it in a communication level, but also in a very specific behavior and health literacy approach. And if we talk about a kind of a value chain of COVID-19 vaccination in Portugal, we must say that we have all of these six important topics. The first one, it was the vaccine procurement, of course, in which probably most of the European countries participate, that allowed us to pick up and to collect the vaccines in a faster way that it was probably supposed if each one of the countries were competing by itself, even though we know it's something that we needed specifically in the beginning, that it was a hard job for everyone because everyone wanted the vaccines as fast as possible. But for countries, for example, like Cyprus, like Portugal, the smallest countries, this was quite useful. The same with the vaccine strategy and recommendations that I will talk to you a little bit more afterwards. That was extremely important to know what to do and to prepare. What would it be our national strategy? Probably you do the same every year like most of the countries do, but we have a 10.3 million population. And every year we provide the population around 2.5, 2.6 million doses of vaccines against the seasonal flu. So for specific groups, but we provide them. So we have already a long history on vaccinating lots of people in a short period of time. And that is really, really useful for us. And believe me, in the beginning of the pandemic, we usually, in the past years, when we talk about this kind of 2 million vaccines, in the past, we were all the time having some spare vaccines, like 100,000, 20,000. So we needed to get some space and we needed to refocus sometimes to, let me use the expression, to solve all our flu vaccines. But since the pandemic, everyone wants to give and to be even more vaccinated against the seasonal flu, which was something really nice to see. And people felt it as an extra protection that they had against this kind of infections. And then the recruitment and booking of the process was also extremely important for us. I will explain it to you a little bit more in detail afterwards. But to receive a text message, to receive or to be possible to agenda in your own terms, in your own schedule, was something really useful, and that allowed people to make it even in a more convenient way. The distribution was also extremely important, and we did it also with the support of the military. So distribution of the equipment, all the logistical procedures were based with the military, and all the organization was defined by that. Then the vaccination itself and the monitoring, which was absolutely decisive. So we needed to have as much tiny as possible of the information so we could get immediately to the points that we needed to tackle. So in some specific regions, we could have some issues. In some other ones, everything could be running soft and smooth. So we needed to go where the needs were more effective in a more precise way. And for that, we consider as one of some of the key success factors, the WHO, ECDC, and EMA recommendations. For some of them, we had to wait and to see what were the recommendations so we can transmit them to the national level. And there was probably one of the first points of trust, and realize that for the first time in the world, but specifically for us in Europe, if you had any situation, any secondary effect with the COVID vaccine in Cyprus, that will be reflected also in Portugal, because that will be a news. But then we forget sometimes that when you vaccinate like 1 million, 2 million, 3 million, 10 million of people, of course that the secondary effects will be more present and will be more prevalent, because the amount of people that you are vaccinating will be huge. But even so, to get one side effect in Cyprus will be a news in Portugal, definitely. And probably the opposite will be also true. So that will bring us and brought us a different challenge. And that's why to work in a broader way, with a broader perspective, will be and was absolutely decisive for all of us. And that's why to be working also within the European Commission and working with the European countries at the same level, it was, I believe, absolutely decisive for the success of everyone. And so we developed lots of norms and recommendations. So we usually use norms, as probably you also use it here, norms and orientations for health professionals. And those norms are norms, we call it mandatory, and the recommendations are not mandatory, but are the pathway that you should follow. And those are made by the General Director of Health, where I work. And these norms are used to give the professionals the pathway, for example, how to provide vaccines, how to use it, how to administrate vaccines. So it's also coming into a norm, which groups and so on and so forward. So again, we try to be as most precise as possible. So we try to get some target communication campaigns to centralize vaccination registry and management platform in something that we call Vaccination, and that we use in a daily basis for the vaccines on the national vaccination program. So we had the COVID vaccines in the same program. We developed, as in most of the countries, mass vaccination centers. And I would like to tell you afterwards, why did we do it and how did we prepare them? Calls for vaccination through SMS or to telephone so you'll receive a phone call and SMS from your local primary care vaccination center. Self-scheduling platform as well, an open house strategy that we use, and some countries also use it. So you could just go passing through a place, and it was written there, it's an open house for people with more than 30 years old. So people just could go inside to give their names and to be immediately vaccinated. So as simple as that. And for that, and also for all of these kind of approaches, we use health literacy and behavior and cultural insights. I will not explain, of course, the health literacy and behavior and cultural insights to all of the colleagues that are here that know all of these concepts, I believe. But for us and in Portugal, we work this as a combination. We know that health literacy, it's not only providing information to people, because if it was so easy and if it was so effective by itself, we could use the health literacy approaches from the 70s or from the 80s, but I usually say that we cannot give a pill of health literacy. Health literacy is a construct that we need to be building up, and it's not useful if you provide them once. We need to build them up as better and as fast, as more effective as possible. So we need to provide people access to information. We need to be where people are, and the last point it is, we need people to apply that same information. Otherwise, as I usually say, we wouldn't have any health profession with overweight or physically inactive or with stress, with high stress levels. Because we all know, even from scientific and strong scientific evidence, what is good for our health. But unfortunately, we don't see that even in health professionals. So, and we don't need, supposedly, to provide this information to those who already know more about it. So we need to tackle this health information. So imagine for health professionals it's so difficult, for scientists it's so difficult, imagine for the population. So we need to put it together with the behavior and cultural insights. It's something that we call to activate the behaviors. And we only activate the behaviors if we have this kind of behavior and cultural insights adjust and working together with the health literacy subject. And so that was what we did. And for that, and allow me to give you the example of COVID-19. Since 2020, in fact, we started in 2019 when all of us started to talk about COVID-19 in somewhere around China, in Wuhan, a place that no one talks anymore. We started to hear about something really weird, a kind of a new virus that was transmitting. We didn't know if it was transmission from an animal to a person, and then if it was from person to a person. And we know that these developments and this kind of communication between the virus from animals to humans are rare, and then to become spreading between humans are even rarer. So this was a big challenge. I'm sorry, and this information was not clear, as if you all remember. And let me tell you something that is really useful. And I was reading the director, and even last week I said the same in a conference, because we cannot hear and we cannot talk about the pandemic in March or in January 2020 as if we were talking about it today. The knowledge that we have today, it's completely different from the knowledge or the lack of knowledge that we had in the beginning of this pandemic. No one closed everything or put everyone at home because they wanted to. We did it as a public health strategy in a way to defend the population, in a way to defend our citizens. With the information that we had back there. Now it seems easier just to say, no, just open the doors, open the windows, be vaccinated, clean your hands, use and sneeze to your elbow. Now it sounds clear, soft and clear. But I remember in the beginning that we had, for example, ambulances waiting 8 hours, 10 hours to try to see with people with symptoms, to which hospital should we go? Is it safe to be like this? What kind of approaches should we have? Because we had so few information that our answer was conservative, as it was in most of the world, and based on the best evidence that we had so far. And that's why since December 2019, January 2020, we built up our first health literacy, behavior and cultural insight group. It was a group inside of the general director that I was coordinating. And that group started to make, in 2 days, we developed a report providing the decision makers, the general director, and also for the politicians, information based on behavior science of how can we improve the person's behavior. Because as if you all remember, before we had the first vaccine, the only vaccine that we had was our behavior. But we knew so just a few things on the COVID, on the SARS-CoV-2 virus, that we needed to provide people this info. For us, I don't know how was it in Cyprus, but for us, when we had the first boom in Italy of COVID-19 and all of the interments and the lethality associated with that, and afterwards in Spain, that was a sign of alarm, a really important sign of alarm to everyone. And I remember that the first cases that we have was a foreign writer that was making a presentation of his new book. And after that, we started to detect cases of people who have been in the north of Italy in a fair fashion fair of something, lots of people there. And then when they come back, and people also on holidays in the north of Italy, and then when they return, we had like the first big boom. But then to explain people why didn't we use masks in the beginning, for example? Something that we call, when you have active community spreading the virus, when it's actively in the community being spread, it means that we don't know how did we get it. But when we follow, and in Portugal we have public health teams, but when we are allowed to follow where the virus spread and from who to whom, since in that part it was okay, because we know we needed to isolate this person. So if I was transmitting to Angelos, we know that in Angelos going to his family and so on and so forward, we knew that if we isolate this family, my family and his family, it will be probably okay. And that's what happened in the beginning. But then when we started to have this communitary transmission, then we knew that was the time to use masks and to make the use of mask mandatory. But we needed to explain all of these steps in a very clear, in evidence and scientific based approach. So with these reports, it allowed us to explain people how the behavior could be transmitted and changed. And this is something also really useful. In the beginning, in March, when we had the first cases detected in Portugal, everything was a disaster in Spain and in Italy with like high levels of mortality. And Portugal was, during this period of time until September, the best example in the world. We have reporters everywhere, BBC and American channels coming to visit us to say, oh, how can you do that? Why did you do that? We were lucky because since we are the most southern country in Eastern Europe, the virus took its way to get there. And even though we can be in Cyprus in 5 hours, or we can be in Italy in 2 hours, and everyone is traveling a lot, the system managed to pick up all of those who were detected with signs and symptoms of COVID-19 and to isolate them. So it was working, I would say, pretty well. But the preparation of the hospitals, the primary care, we did as most of the country did. The focus was COVID-19. With the problems that it brought us then, and we'll highlight it now, specifically with the chronic disease, with the diseases that were not detected back then, and now have a two-year delay on the detection of those diseases. And we need now to be aware, and we need now to tackle it urgently, because they are really, really a very important issue. And we still know, I don't know if it happened the same in Cyprus, but in Portugal, for example, in the last year, for the first time in decades, we decreased our life expectancy. So we were like in 83.2 years old. So Portugal is one of the oldest countries in the world, but also one of the countries where people live longer. And for the first time in decades, we decreased that life expectancy at birth because of the lethality associated with the COVID-19. And this is a new change in the paradigm that we had in these years. So also in March, we developed a project that we called Micro-Influencers in March 2020. I will tell you about it a little bit afterwards. And in September, we developed a health literacy in COVID-19 action plan. And in 2021, also in March, the government decided to promote a task force on behavior and cultural insight, so we could specifically tackle all of these issues. In March, we start also our vaccination preparatory reports. I will let you know also about it afterwards, as well as in May, the second report. In March 2022, our vaccination predictors report, the third one, was also made, and I will show you our results. So for our intervention, our health literacy and BCI intervention plan was developed in 4 major axes. The first one was to collect good practices on health literacy. So what did we know about health literacy, and how can we use it to tackle this, something that is really weird for us, which was facing a pandemic? Because we develop our health literacy projects facing the non-communicable disease that represented for us 86% of premature mortality and 88% of the burden of diseases. So it was something absolutely huge. The second X was something that we developed and that we called health literacy intelligence. So we tried to pick up all of the information from different sources using the new methodology, and based on that information, we customized our communication, which was our third X, to communicate. And we tried to be where people were. We developed campaigns and we developed strategies, for example, with Facebook, Instagram, Google, something as simple as this. With Google, we managed to have our national website to be the first one on the list when we search for COVID-19, when we search for pandemic, when we search for behavior, when we search for health. So the keywords that we gave to Google, and they allowed us to be the first one, the first option. And we know that people usually search or press on the first option that they have when we Google it something. And that was really, really impressive. In the beginning, in the first months, we had already more than 100 million entrants in our website. It was crashing all the time. So it was also a challenge because the search was so much that we needed to do something else. But also for communication, we tried to be as much as people were. And for example, we knew that it was floating the demographic parts of the people who were getting COVID. And we know that in the beginning was more on older people, and then on youngsters, and then people on working age. So we tried to customize as much as possible the recommendation for all of these groups. And sometimes people were telling me, I haven't received nothing. And I told them, that's perfect, because it was not for you. It was for your kids, the focus of this communication. And the opposite was also true. And then I will let you know also how good we managed to organize some other information. And then social mobilization, which was something that we usually put and write down in a very proper way to make like population engagement. But we thought, okay, that sounds really good, but how can we do it? How can we engage population? How can we involve people? How should we do that? And that was a challenge that I also would like to share with you. And also something that I felt it was really, really useful. This was our, I don't know if you see this graphic here. This was our risk perception graphic. It was based on the different collecting information from different social network, from information, for communication, from specific groups. And I don't know if you can see there, I will take the opportunity to stand up just to show you something. I hope that you can hear me. This dot here, the first one and the second one, the lowest ones, were when we started. So in the beginning, when we had no cases of COVID-19 in Portugal. And the second one was when we detected the first case of COVID in Portugal. Because a phenomenon was happening. People were seeing that COVID was everywhere in Europe, but in Portugal, no case was detected. So we had lots of cases, suspected cases, but then after people did the testing, they were not COVID, until we had the first case. And I believe that people then felt more or less confident, okay, so we are detecting something, but it's not as huge as in some other countries. So to have this time also allowed us to prepare to what was coming. And people felt, okay, we have the first case, so that's okay, we detected it. And then you have like a rise on the risk perception because we're starting to have more and more and more cases. And the peak that you have there in 2021 was when something happened. Portugal was the example to follow, but then even though it was like a political possibility and a political recommendation, and that should allow us to think now about the importance of behavior. We had all of those restrictions since March, where people had to stay at home, and then afterwards, in a later stage, where we had to do the same. We have a very good summer with low cases, 10 new cases every day, so it was more or less close to nothing. But then, for Christmas, there was the possibility, in Christmas and New Year, there was the possibility to people to travel again. And then we had issues because everyone, even though all the recommendations was, please do it in a small group of people, please do it only with your internal family, people didn't do that. We were passing like 1 year without seeing anyone, with traveling difficulties and restrictions. And then we gave all the responsibility to the citizen. And that's not probably correct. And the results were catastrophic. And then Portugal, that was the world example, suddenly started to be having the worst results in the world, with the lethality, so the mortality associated to the disease, huge number of new cases. And that was also with the B5 variant, which was highly transmissible. So it was like a cocktail that no one was expecting, that it was really bad for us. So until that period, until February, we had a huge challenge for not only for hospitals, but also to all the public health departments. And the virus was spreading everywhere. And on the right side is an example of the reports that we were promoting, health literacy and behavior and cultural insights reports that would give us, like we put it like a color, to be easier for the decision makers to understand what we felt it was like high risk or lower risk on the interventions. And then the graphics were, of course, all along with the new cases that we had. All of these red dots showed us some specific moments. So when we start the first lockdown, when we provide the first regulations, the first norms, and so on and so forward. And that was something really useful. That was public. Those ones were not public. Those ones are only for the technical and political part. So we did our best to promote the campaigns through social media, to communicate. I don't know if it happened the same here in Cyprus, but for a long time, people started to see again television. The public channels, the public television was getting rates as they didn't had for 20 years, because people were at home, and suddenly television, for example, for the youngest that usually go to YouTube or Instagram or other social networks, suddenly everyone started to see television again. And we used that. We invited the 4 main TV channels in Portugal, and we did something that earned some prizes in Portugal, but the prizes are not the most important. The effectiveness of it, that's the most important part. We divided our intervention in 4 different pathways, and it was in our norm number 4, probably one of the most important. So when we had like lots of cases happening, we had to tell people about, so if you are having high severity COVID-19 symptoms, medium, low, or no symptoms at all. So what should you do in one of these 4 cases? And for us, we decided to invite 4 TV news presenters, and all of them were giving a pathway, and they were representing it as if it was for themselves. And at the same day, at the same hour, it was 18 minutes, all the 4 main channels were giving the same report. And the reporters that were present there was the same that were presenting the news. And that was absolutely impressive because we reached more or less 4.5 million people at the same time. It was impressive. So we explained people with this example, what should they do if they were having these kind of symptoms, signs of symptoms related with the COVID-19. That could be only calling to our hotline, a health hotline, that was extremely useful, or to go to the hospital to call a nurse or a medical doctor, or to call emergency department. And that was really, really amazing. And then also based on health literacy and behavior and cultural insights, before we start our vaccination campaign, we did 2 reports on vaccination intention and barriers. So we knew before we started who were the population frames probably less adherent to be vaccinated or that really wanted to be vaccinated. And also what were the barriers to vaccination. And that allowed us a lot to customize our communication and to tackle and to focus really on those that we knew that probably will be more hesitant to be vaccinated. And that was really, really useful for us. We knew that it will be probably a success because everyone said that want to be vaccinated. But we had a frame of people with a high education, around 40 and 45 years old, that were probably the most hesitant. So we focused our intervention to those specific population when we were communicating to them. We also knew that if you have a vaccination center close to your home or to hometowns with a difference of, it had to be closer than 10 kilometers. More than 10 kilometers, it will be something that people didn't want it. It will be a barrier to be vaccinated. We knew that if I want to reach there, to stay there and to be vaccinated, it will be very good because people, even those who are hesitant, would just go there and be vaccinated. And so that's why we tested it before. We also monitor during all the pandemic if people were understanding our communication and if they felt that it was being clear for them. And we knew that this was a national sample made with around 6,000 people from the different Portuguese regions. And we knew that 78.8% of people were reaching or searching information on health and healthcare, not only from COVID, but official information. And that 94.4% of those people were able to access information about COVID-19. That gives us a pathway, that gives us some kind of confidence on what we were doing. I'm sorry for this graph, this should be like in the opposite, but that graph on the right side, it tells us that around 94% of population understood as only sometimes or never difficulties in understanding the official information and communication that was being provided on COVID-19. What's for us, it didn't allow us to relax, of course, but told us that, okay, so the way as we are communicating is probably effective. So people are getting the message. But this is something different from getting the message to getting the behavior. We are talking about 2 different aspects. That's why we are hand-to-hand with health literacy and behavior and cultural insights. Why? Because of this. Because our risk perception and the perception of responsibility are 2 completely different subjects. We knew in the beginning that people were afraid. And when we are afraid, because the images that we saw, people intend to trust more in the recommendations that are provided. But we also know that to be afraid and to promote fear, it's not correct for several reasons. And if we pick up the scientific basics, we know that fear works for a short period of time and it doesn't work in a long time. To promote fear is not sustainable. And it's not even something that we want because it's not clear for people. People do it because they are afraid, not because they understand why should they do it. So we should prevent as much as possible to promote fear. And we saw some campaigns like people connecting to machines and with the beeps and so on. The effectiveness of that is zero according to the scientific approaches and with the meta-analysis that we see everywhere. To promote fear, it's not correct. So we need to promote behaviors, and I will let you know as best as I can how did we do it. So the risk perception and the perception of responsibility should be hand in hand, but we don't want to give all the responsibility to people. Just like tell, okay, you are responsible for your own health. That doesn't work as simple as we think. People need to have more than that. And it needs to provide something that we call to promote an ecosystem that allows them to choose the correct way and the correct approach. And for that, we use the behavior and culture insight, the public health approaches, and the public health policies. And this is the combination that we needed to use as most effectively as possible to provide people the needed information and the needed approaches that they need to take. So it's a combination of different strategies. And for that, we need to divide it like more or less in three different ways. Okay, I told you that I was be seated, but I can't do it. Sorry, my apologies. But we try to do it in three different ways: with protective behavior, with triggers, which are activators of the behavior, and with behavior reinforcement, because we need the behavior to be sustainable. And imagine this, that is happening all over the world. We offer people SABA everywhere, so the alcohol solution. Nowadays, we are going everywhere, and and it's hard now to find not only the solution, but machines that are charged. Because most of the times now, at least for me, I press it there and nothing comes out because people don't charge it anymore. Probably most of you still have some masks on your pockets. And if you all remember, in the beginning, we used masks, and if we touch, it will work out. Yep, it does work. Thank you so much. So scientific proof of the things that you are saying. But imagine in the beginning, if you put a mask, if we touch with our mask on a table, we'll be, oh my God, that mask will not work anymore. I will immediately put it on the trash. So we use it like in a very, our approach was really focused. Now we use our mask in the pockets everywhere. We know a little bit more about the virus, so we know it's more or less okay. But even though our behavior is changing, because our ecosystem, it's again changing. So if we want to keep our health promotion, our health perspective facing the COVID sustainable, we need to tackle it in at least these three approaches. So we need to make it simplicity in schematic. And this is only some ideas of what we have done and some ideas also for the future. So we need to have behavior triggers and activators, more or less with communication products. For us, it's quite usual even to find some postcards. The first ones even saying, if you travel from China and if you have these symptoms, come on, it says 2 years, it's 2 years old, it's trash, it's not useful anymore. And we know that postcards are useful, to communicate in the media is useful, or for example, leaflets, and we saw it, lots of them in the hospitals, in primary healthcare. We know with scientific basis, a leaflet works if it's delivered by a professional, if it's read with the professional, then it's a tool. If you live in there, at least in Portugal, when it's hot, it's good for taking it, and you can do it like this and you feel a little bit comfortable. It's not worth for nothing else if it's not explained. It's not a tool, it's a paper. Then something that we really need to do to become and to make the easy choice, the simple choice. And let me give you an analogy, an example. If outside of the university, if we have bars selling beer, of course that the students will go out and drink beer. The same with candy shops, in front of children in schools. If you have candy shops, kids will take candies after they are leaving the shop. The same is something that we need to do. If you have in your house an opportunity to run or to make physical activity, the probability for you to practice physical activity is much higher than if you don't have any resource in front of you. So we really need to promote and to make the ecosystems as friendly as possible, as easier as possible, to promote the healthy choice, the easy choice. And that's one of the major challenges that we need to promote. And then to support with technology in compliance with protocol and appropriate behavior, and then to provide responsibility and to promote micro-influencers that I will let you know a little bit. I think we still have 10 minutes, more or less. Okay. So I will try to be as fast as possible, not to bother you also, and to prevent something that I call, which is a disaster, and people start to, that's not good, feeling everyone. So let's try to prevent that, yeah. So that is something really useful for us, and let's try to tackle as much as possible. So we also need triggers, and to trigger the behavior, we need the behavior and cultural analysis and intervention in every opportunity, and also a constant and permanent risk perception evaluation and perceptions of responsibility. And that risk evaluation that we have done, it's something that we are also continuing, not only for COVID, but also for other diseases. And that was absolutely decisive for us because it allowed us to customize the information, to see what were the major issues. I usually say it was more or less close to a sausage factory, because we collect the risk information perception, we work with BCI and health literacy, and then we send them to communication so they could spread it to the most effective channels for that specific and target population. One size fits all, it doesn't work in public health. It's something that we know that it's meaningless. And then for behavior reinforcement, we have to reinforce recommendations over and over again to make them sustainable. The recognitions of services and professionals, if they're complying with the information, it's also extremely important because we have to communicate to the outside, but first we need to communicate inside to tell the professionals what should they do, how should they do it, in which kind of tools do they have. For example, when we start the vaccination campaign, we develop a leaflet for health professionals, mainly to nurses and to medical doctors and to pharmacists, was the three groups that we focus more with this recommendation. What to do and what to say if a person wants to be vaccinated, if he's hesitant, or if he doesn't want to be vaccinated. So we uniformize this approach, and all of people knew what to do and what to say, without having to think or to having different answers for the same problem. And that was something really useful, and this is BCI, this is health literacy. So to provide this kind of tools for people to develop, it was only a leaflet. And then to develop, of course, health literacy. To facilitate all of the personal responsibilities, we needed to have like these four major points. To make it clear and transparent all the time, trustful information, social cohesion and belonging, and participation. And that's why patient associations, for example, had such an important role within all of these developments and for future developments. It's decisive because when we talk about co-creating, when we talk about sharing the information, we all need to be involved. We all need to be on board. And the beautiful thing about COVID, it didn't brought anything good for us, but the beautiful thing about it was that we were all facing the same problem and we were all together to tackle it. And people focused. And when we focus, we make it happen. And that was something that I believe it's really useful. So almost to finalize it, just some key success factors. So mostly big sports halls, for example, when we talk about vaccination centers, were used as everywhere in the world, but also shopping centers. So mostly places where it was easygoing and close to populations. That was really a success factor. So the admission, the delivery of questionnaire about precaution and contraindication was provided to people in the beginning, asking them, do you have any allergy? How do you feel, confident or not? So people were just like 1 minute questionnaire that they filled up, but that was important for us. And then there were all the time clinicians, ambulances presented, so we could provide them a trustful environment for people. These reports on the predictors and barriers, as I told you, were decisive for us. They allowed us to get previously information, so what to do next and how to prepare it. And then our social mobilization, something that we call micro-influencers. We are now being evaluated by WHO with this project because we train more than 5,000 micro-influencers all around the country. And this was something so good that I'm really proud. I usually say to my colleagues that this is something that our grandsons will hear about it, because it was absolutely amazing. We trained people that were not the usual people. Since all the medical nurses, psychologists, everyone was with the amount of work that was unbelievable. This was our way to engage population. And we engaged some of them more than these groups, but some of them were from these groups. Psychologists, dentists, pharmacists, social service workers from the municipalities, civil protection, firefighters, the National Guard, the police, and we trained them all in 3 different stages. The first one in March 2020, telling them what was this virus, how was the virus transmitted, and how could we communicate the recommendations for the population. And we gave all of them communication skills and also a communication toolkit. So everyone was using the same information. So you could be stopped if you had your mask, not put it in your pocket, but like here, you could be stopped by a police officer and he would tell, instead of asking you for your ID or your license, he will tell you, okay, so please put your mask correctly, like this. And he will show you a picture of how to use correctly your mask. So instead of having a more aggressive, so to say, approach, we had like a health literacy promotion approach, not like with violence or giving you a ticket. It was like in a good way. And then for those hard to reach populations, I work in Lisbon, but I'm from a part of Portugal. It is Alentejo. It's an inside part close to the border with Spain, where we have the population is few population. It's getting this desertification is really an issue for us. And we know there are a lot of old people living alone. So the National Guard as a program, and we know that they have, so they were there explaining, because people with 80 years old, even though they were looking to the media, they probably didn't understood what was happening. So they have someone that could explain in their same language, using images, with time, with cultural issues, explaining them, okay, so this is what is happening, this is what you should do, please watch it. And then these micro-influencers were also very good because they allowed us to get retro feedback, as I usually say, because they told us, for example, in schools everything is perfect, but then we have an issue. The National Guard told us, all the kids come together outside of school. Inside of school, they all are taking the distance and everything is perfect. But then when they are going home, everyone is going together and drinking and doing the things that they usually do. So that allows us also to take some measures and to tackle also these issues. So, and again, with the social services, it also allowed us to collect information and to reach people that usually we haven't reached. So this micro-influencer project was something really useful, as well as to communicate with health professionals. We did some training. I usually tell a story, but we don't have any time. When my daughter was born, I took 40 minutes to close the wheel, the chair. I took like 40 minutes to close the chair. It was the first time that we were going out for a dinner, and I thought, oh my God, this in the shop, it was so easy. Now I cannot do it. In like 40 minutes, the kid was already in the car, seated. My wife was not happy because it was 2 weeks after she was born. And I thought, okay, there must be something that could help me. And I went to YouTube, and there was like a video explaining how to put it together, how to close it, and how to open it. It was a saver. And the same strategy we use for health professionals, to get like short videos explaining all the norms and all the orientations. So how to do it and why we are doing this. And this internal communication is absolutely decisive. And then we try to occupy as much as possible the communication space on TVs, on radios, with leaflets everywhere. On social media, we try to be as much as possible present, because we had a new challenge that I would like to take for our discussion, because suddenly with COVID-19, we started to have a challenge that was curious and we didn't have so far. Something that I call expert versus expert. Should we use mask? One of the experts says, yes, we should. The other one says, no. And for people that are at home, who to trust? Who to trust? An expert versus an expert. Should I get vaccinated? Yes. This one, probably no. So who to trust? Fortunately, in Portugal, people do trust in institutions and do trust in health professionals. But then when you have two health professionals, then you can raise questions. And usually, do you know what happens? They usually trust in people that communicate better. So that's also why is it so important for health professionals to communicate well and to know how to communicate. And that's a different-headed challenge for the future. And I will be really fast now, and I will pass all of this because we are really late. I'm so sorry. So the emergency of developing a task force on social, on behavior and cultural science was absolutely decisive. We have all of these aims and challenges that I already told you. But to finish it, let me tell you that the challenge for the future will be to have health literacy and behavior and cultural insights in whole health policies. That's really, really important. And then probably the greatest challenge as all. This is a definition from the United Nations that I really love that makes different two concepts, lessons identified and lessons learned. And in the world, we are absolutely amazing, especially us in the Mediterranean countries. We identify all the lessons. We are brilliant doing that. But then to learn the lessons, that's another issue. And we do the same mistakes over and over and over and over again. That's why I love this definition. And I really do hope that we learn to not only to identify, but to learn the lessons. And my final slide. This was something that I took. I didn't ask permission of these two ladies. My apologies. But that was something that I felt this is it. This was in a new recent area in a city in Portugal called Aveiro. It's a very beautiful city. They have sweets that are amazing called ovos moles. So if you are going to Portugal, you have to try it out. I'm so sorry. I should have talking about it. I should have brought like some cases of it. But next time I will definitely do it. But this shows something amazing. This is a new road, a new urban area, and this is something that I usually say. This was made by the engineer and by the architect, and this was made by lots of people. Because sometimes people just want to be the fastest way from point A to point B. But some other ones like to come from point A to point B probably in the step that they want and that they need. And at the end, I believe that even though we are not architects or engineers, we are architects and engineers in behavior, in medical science, in health. So we need, when we are building something, not to design things as we think they work, but to design things as people really need it. And this picture, I believe, it's one of the best examples that we have in real life. Just sometimes we just need and we just want to get from A to B as fast as we can. So it's an idea in food for thought for the future. Thank you so much for your help.
Thank you very much, Miguel, for the excellent presentation. I think listening to you, I was also, apart from seeing all the amazing work you keep doing, I think I was also reflecting on how we performed in Cyprus, and I'm sure that the audience may have some questions in terms of that and in terms of your presentation. We're a little bit behind time, but let's spend 5 minutes, 7 minutes for questions, because I think it's important for sharing this kind of information. So, any questions from the audience? Yes.
Hello.
Sorry, just a second to bring the microphone.
Thank you very much. Hello. Good. I am the health visitor in charge in Limassol city for the organizing of the vaccination, or for the COVID vaccination department and mass vaccination of COVID-19.
When we think that it was successful, this all organization, we're seeing now that there's a lot of people that are not willing to do the booster doses, and we see a lot of theory of fear coming in about the vaccinations. And also in media, we see different people talking about the dangers and the side effects or long-term effects of the vaccinations. So I would like to know what is the situation in Portugal about this.
Thank you so much. And first of all, please allow me to congratulate you to accept that huge challenge for your nation. So I must say that health professionals are really true heroes, and those people that accept challenges like you did, it deserves everything. So thank you so much.
Thank you.
Really. And then for answering to your question, one of the things that I believe that it's most important for us, it's to, as I told, occupy the communication space. Because when we don't accept, and it's quite usual for health professionals that, no, I want to be my clinical part, I want to stay in my job. When we do that, we are opening space for the communicators to say some things. I will take the liberty to make a joke. There are some experts that I saw during the pandemic that I'm also seeing in the Portuguese television talking about the war in Ukraine. Unfortunately, I have not the capacity to talk about two different subjects, completely different, or to be an expert in two different fields. I also like to live in a country where people can express themselves, but we need to clarify some of the things that probably are being said sometimes. So that's why this risk perception and this risk evaluation and monitoring of the media and social media, I think that should be provided everywhere, because that will allow you not only to see what is being said and not to make it scale up. If you are looking to the news, if you are looking to the information, if you are seeing there are behaviors that are being changed, we need to tackle it immediately with the most recent evidence. But we cannot communicate science or evidence only showing the graphics like I showed you, because for the population it doesn't work. We need to provide them, for example, in telling that mortality just like decrease it like this, and then to keep on preventing this virus to spread again, we need to keep on doing this. It's a challenge, it's a huge effort, but you have to count with everyone. So we have to make it again as a community approach, as a national based intervention. Maybe it's not.
No, it's okay.
Oh, it's okay. So I would say that to occupy the communication space and to develop a communication strategy with behavior and cultural insights, I would say that it's probably the best strategy that Cyprus and every country, like we are trying to do also in Portugal, will do, not to allow the small issues to become big questions.
Yes. Thank you very much.
Thank you.
Thank you. Any other question? We have time for another question. If anyone has anything to ask? No? Thank you again, Miguel. It was a really, really great pleasure. I think one of the things that I was really impressed with is how you managed to correlate all the evidence, right, from the literature and the scientific evidence, and also the models that we have been using theoretically to understand how people behave, and you used it in translating it into real life policymaking. I think that's a big lesson. And I don't know if you can tell us if you can select the biggest challenge that you faced during the pandemic. What would that be, and how would you then consider that for the future?
Thank you so much, Angelos, for it's really a hard question, because the challenges were huge. I would say that if we talk about that challenges and lessons learned, I would say that the work with academia, it was really, really useful and really, really impressive. But then, this is also my background. Before I was going to the general director, I was also a professor in the academia. I'm still am. But that's the thing that you said. I think for me, it's the best one. We need to pick up and we need to bring science and to promote science that is clearly useful. especially when we are facing these huge challenges, and to work together with the academia, but to focus on things that really change person's life. I would say that is probably one of the best learnings that we had. But to adjust the timing, it will be really, really important. And probably, and I was thinking, probably the biggest challenge that we need to face was to learn how to communicate uncertainty, into uncertainty, and tell people, okay, so we know this now. It doesn't mean that tomorrow probably will change, and we cannot say it in we cannot lie, first of all. And if we don't know, we must say that we don't know, but we have to show people a pathway. We have to show them what are our mindset. Otherwise, people will think that we are completely lost and that we don't have any goal to reach. So that's why we use some expressions like, for public health precaution, we take these measures. But, or even though when we decrease the public health measures, we told them, okay, we are decreasing, but it doesn't mean that next month or in 2 weeks, if the epidemiology shows there is an increase, we will again return for the use of masks or for the social distancing or to other more hard public health approaches. So I think that to communicate uncertainty will be one of the biggest challenges, because we don't have science. The times of science and the times of the needs that we had were different. Thank you.
Thank you very much. So, Andrea, I think now we'll have a 15-minute break. There's coffee and biscuits outside, and we'll continue quarter to 12.
Thank you.
Thank you. Thank you so much.
Proceeding to the next session, I would like to call on stage Dr. Christiana Nicolaou, Assistant Professor. Sorry, you're standing here. So, in Pediatric Nursing Care, Department of Nursing of Cyprus University of Technology. Dr. Nicolaou, the stage is yours.
Thank you very much. Hello, everybody, and thank you very much for joining this seminar. I'm Dr. Christiana Nicolaou, and I'll be chairing this session where the results of the SAFES project will be presented. SAFES is a co-funded project by the European Regional Development Fund and the Republic of Cyprus through the Research and Innovation Foundation, with partners the Cyprus University of Technology, the University of Cyprus, and the Cyprus Medical Association. The aim of the study was to examine the social contagion of vaccination beliefs and attitudes of parents of primary school children through their social networks. Opposition to vaccination has seen an increase the last 2 decades. Internet and social media have a significant role in spreading anti-vaccination beliefs, but how the beliefs are formulated and transferred is still unknown. So we need to understand and monitor the mechanisms behind the social transmission of beliefs, attitudes, and messages related to vaccination, especially in the context of the recent pandemic of COVID-19. In this session, 4 speakers will present the SAFES project results and conclusions, and also another one speaker who was not in the program will present the causes of COVID-19 and the vaccination movement in Cyprus. At the end of the session, 5 minutes will be given for questions. The first speaker is Mrs. Timelopi Konstantinou. Mrs. Konstantinou is a PhD candidate in clinical psychology at the University of Cyprus, and she is currently working as a research assistant at the SAFES project and InfoCaine project. Mrs. Konstantinou will be presenting a research study which investigated the predictors of COVID-19 vaccination, intention and uptake based on the COVID model. Mrs. Konstantinou, the floor is yours.
Thank you very much. Hi, everyone. Today I'm going to present you our study with the title Predicting COVID-19 Vaccination Uptake based on COMBI model. COVID-19 pandemic affected millions of people worldwide with increased mortality rates, especially in vulnerable individuals. COVID-19 has brought massive challenges to public health systems worldwide. Vaccination hesitancy was an important barrier for achieving herd immunity against COVID-19. It is defined as the delay in acceptance or refusal of vaccines despite their availability, and it consists one of the top 10 threats to global health. In order to reduce mortality rates, COVID-19 vaccination hesitancy should be reduced. Therefore, it is important to understand the mechanisms that drive people towards greater vaccination uptake in Cyprus so as to better design intervention programs. However, before delivering and designing an intervention for increasing COVID-19 vaccination uptake, it is important to determine the approach that should be adapted to increase effectiveness. One of the most widely used models of behavior change consists of the COMBI model of behavior. The COMBI model of behavior identifies what needs to change for an intervention in order to be effective. According to the COMBI model, 3 factors need to be present for any behavior to occur: capability, motivation, and opportunity. Capability refers to the psychological and physical capacity to engage in a particular behavior. Motivation refers to the reflective and automatic processes influencing this particular behavior, and opportunity refers to the physical and social environment making this behavior possible. Overall, the aim of this study is to better understand which factors predict higher COVID-19 vaccination uptake based on the COMBI model, specifically to what extent greater knowledge and understanding of the vaccines, greater opportunities for vaccination, and or motivational issues predict higher vaccination uptake. Data for this study was collected through a randomized controlled trial examining the effectiveness of a values-based intervention and public health messaging on COVID-19 vaccination uptake. For more information about this study, you can find on the link here. There were 2 time points, baseline and 2-week follow-up. Before conducting the study, power analysis was conducted, indicating that a minimum sample size of 92 participants is required in order to provide medium effect size. Early university students living in Cyprus, aged 18 to 35, were eligible to participate. Regarding the criteria for participating in the 2-week follow-up, participants should have not received the initial COVID-19 vaccine dose or have not taken the booster vaccine. Participants were recruited from emailing lists from the University of Cyprus, University of Nicosia, European University, and Cyprus University of Technology. Regarding the procedure for the baseline phase, data was collected from RedCap, and prior to completing the survey, participants provided informed consent electronically. The average duration of completing the survey was 10 to 15 minutes, and participants completing all the parts of the study participated in a draw for gift voucher. Regarding the 2 weeks follow-up, all eligible participants were sent a link in their email to respond to the questionnaire, with average duration of completing the survey was 5 minutes. Now, regarding the outcome measures, vaccination uptake at first phase, referring to whether the participants were vaccinated with at least 1 dose or not, and vaccination uptake at second phase, referring to whether the participants got vaccinated in the last 2 weeks. Also, vaccination intention at first and second phases, referring to whether the participants who were not vaccinated were planning to vaccinate. Regarding the predictors, the COM-B model scale was used, which includes 5 items rated from 0 to 10. This scale assesses perceived capabilities, opportunities, and motivations in relation to behavior change. And higher score in each item indicates higher perceived physical and social opportunity, motivation, and physical and psychological capability for vaccinating against COVID-19. Regarding the statistical analysis, because we are still analyzing the data, I will present you some preliminary findings, and also the statistical analysis will be refined. The SPSS statistics is used, and hierarchical logistic regression models were run. Specifically, in Model 1, the physical opportunity was added. In Model 2, Model 1 predictor and social opportunity was added. In Model 3, motivation and Model 2 predictors were added. In Model 4, physical capability and previous predictors. And in Model 5, the psychological capability and all previous predictors were added. For the outcome measures, as I previously mentioned, vaccination uptake and vaccination intention at phase 1, and vaccination uptake and vaccination intention at phase 2 were added. Overall, at the baseline phase, 484 participants completed the study. Most of them were females with age almost 26 years old. Most of them were living in Nicosia and studied in the University of Cyprus. Also, the majority of the participants had as highest education level being bachelor degree. Regarding vaccination uptake at phase 1, 23% of the participants reported that they were unvaccinated, and 77% of the participants reported that they were vaccinated with at least 1 dose. Specifically, 2% of the participants were vaccinated with only 1 dose, 29% of the participants were vaccinated with 2 doses, and 46% were vaccinated with all doses. Regarding the outcome of vaccination uptake at phase 1, when all of the predictors were added in the model, higher motivation and higher psychological capability increased the probability of being vaccinated with at least 1 dose by 1.77 and 1.39 times, respectively. regarding vaccination intention at phase 1 in unvaccinated participants, when all predictors were added in the final model, we found that only having greater motivation increased the probability of intending to get vaccinated by 1.44 times. Regarding vaccination uptake at second phase, I should note that 111 participants completed the study in the second phase, and from those, only 11% of the participants actually got vaccinated in the 2-week follow-up. Specifically, when all predictors were added in the model, no one of them significantly predicted vaccination uptake at second phase. However, when they were added alone, having higher social opportunity and higher motivation significantly predicted greater vaccination uptake at second phase. Finally, regarding vaccination intention at phase 2 in unvaccinated participants, when all predictors were added in the model, we found that having greater motivation increased the probability of intending to get vaccinated by 1.42 times. Overall, combined with findings of previous studies, the COMBI model was found to be a strong predictor of COVID-19 vaccination uptake in Cypriot population. And more specifically, when all COMBI factors were examined together, motivation was the strongest predictor of vaccination intention and uptake in both phases. Also, psychological capability predicted vaccination uptake at phase 1. However, for the other COMBI factors, results were not significant when they were added all together, and they were added and significantly predicted COVID-19 vaccination intention and uptake when they were added alone in logistic regression. Therefore, policymakers and public health authorities are recommended to focus on changing or increasing the motivation of younger population on being vaccinated for COVID-19, and more specifically, they can engage people as part of the solution and promote self-efficacy and positive behaviors. For example, they can ask them to discuss their concerns and misperceptions, or enlist trusted voices in health messaging and showcase those who have tackled COVID-19 in a positive way. They can also acknowledge the hardships that people face or fear on COVID-19 vaccinations and show empathy and understanding instead of punishment and blame. And they can consider the benefits of being vaccinated and use them to make vaccination a more desirable option than being unvaccinated. Finally, in order to improve psychological capability, they can create and maintain accessible educational resources on COVID-19 vaccinations tailored to the needs of younger populations. Before closing, let me say special thanks to all the team that contributed into this research, and more especially the University College of Dublin, Dr. Liz McHugh and Dr. Nigel Vahi. Thank you all for listening to me.
Thank you, Mrs. Fanu, for this excellent presentation.
Yep.
There are questions again.
Yeah, okay.
Now, the next speaker is Dr. Maria Kyprianidou. Dr. Kyprianidou received her PhD in field of environmental and public health with specialization in biostatistics in the International Institute for Environmental and Public Health at Cyprus University of Technology. She is currently working as a research scientist in the SAFES project and also as a special scientist at the European University of Cyprus. Dr. Kyprianidou will present the results of a multi-country longitudinal study which examined the factors that may influence vaccine hesitancy. Dr. Kyprianidou, the floor is yours.
Thank you, Dr. Nicolau.
Hello, everyone. My name is Maria Kyprianidou, and I'm going to present you the results of the multi-country longitudinal study of this project. My presentation is divided into 4 main parts. First, I would like to give you some information about the background and the measures of this study. Then we're going to discuss about the results of a cross-sectional study which conducted in 6 European countries prior to this longitudinal study in order to examine the measures and the hypothesis of the present study. So after this, we can discuss about the aim, the methodology, and the results of this longitudinal study, and of course, the main findings. I will start from the background of the study, but I'm not going to give you a lot of information because Penelope already mentioned a lot of things about vaccination hesitancy. I would like only to mention again that the several factors which may influence vaccine hesitancy are socio-demographics, behavioral, attitudinal, and psychological characteristics. For that reason, the measures of both studies, cross-sectional and also the longitudinal study, were the follows: socio-demographics, COVID infection variables, the 7C scale, attitudinal, behavioral, and psychological or emotional determinants. So, first of all, we included the socio-demographics in the study, including country, age, gender, family status, and all the others, as you can see. Secondly, we have COVID infection variables, and specifically, we wanted from the participants to answer if they diagnosed with COVID-19 or if they knew anyone in their social circle diagnosed with COVID-19 too. Regarding 7C scale, because it's the main scale, the main predictor of this longitudinal study, I will give you some more specific information in the next slide. But I would like just to mention here that 7C scale consists of 7 items, namely confidence, complacency, constraints, calculation, collective responsibility, compliance, and conspiracy. Regarding the attitudinal determinants, we have the pandemic fatigue scale, which consisting of 6 items with 2 subscales, namely behavioral and information fatigue, each consisting of 3 items. The institutional trust has 4 items about the trust towards the state authorities, the trust in the international health organizations, the trust in pharmaceutical corporations, and the trust in the healthcare professionals. Finally, in the attitudinal determinants, we have the cognitive risk perception, which consists of 3 items. 2 items refer to the probability of being infected with COVID-19 from the family or by someone totally strange, and 1 item about the severity perceptions if they contracted COVID-19. Regarding the behavioral determinants, we have the adherence to COVID-19 behaviors, which consist of 6 items about keeping distance, limiting unnecessary traveling, avoiding crowded areas and closed rooms, washing hands, and wearing a face mask. And lastly, about the psychological determinants, we included the affective risk perception, which consists of 3 items about how often the participants of the study think, terrify, or worry about COVID-19. So, for the 7C scale, before the 7C scale, 5C scale was conducted in order to provide a novel tool to monitor psychological characteristics of vaccination and also to facilitate diagnosis, intervention design, and evaluation. These 5 items were the confidence, which mentions that I am completely confident that vaccines are safe. Constraints, which mentions that everyday stress prevents me from getting vaccinated. Complacency, which refers that vaccination is unnecessary because vaccine-preventable diseases are not common anymore. Calculation, which refers that when I think about getting vaccinated, I weigh the benefits and the risks to make the best decision possible. And finally, the collective responsibility, which mentions that when everyone is vaccinated, I don't have to get vaccinated too. After the 5C scale, 7C scale was conducted based on the previous 5C model with the addition of another 2 items. Compliance, which mentions that it should be possible to sanction people who do not follow the vaccination recommendations by health authorities, and conspiracy, which mentions that vaccinations cause diseases and allergies that are more serious than the diseases they ought to protect from. So, as I said before, I'm going to start with the result of a cross-sectional study which aimed to examine the socio-demographic, the behavioral, and the attitudinal characteristics of the vaccine hesitant and acceptors, and also to examine any cross-country differences to vaccination hesitancy among the 6 European countries which included in the study: Cyprus, France, Germany, Italy, Poland, and Spain. We used the REDCap software in order to collect the data between December 2020 and January 2021, and of course the study was approved by the Cyprus National Bioethics Committee. In total, 832 participants were completed the questionnaire, with the majority of them being Polish, followed by Italians, Spanish, Cypriot, Germans, and French. A vaccine acceptor was a participant who responded yes in any of these 2 questions. Have you been vaccinated with the COVID-19 vaccine? And if not, do you plan to get vaccinated if a COVID-19 vaccination will be available for you? While a vaccine hesitant was a participant who responded no to the second question. Approximately 20% of the participants of the study were COVID-19 hesitant. We performed a discriminant analysis in order to create the profile of a COVID-19 hesitant. And we found that an individual who was a COVID-19 hesitant was a person at a younger age, living alone in a place with a lower number of residents without children. Also, we found that a vaccine hesitant participant reported less worrying about the severity of being infected, lower institutional trust, less adherence to protective behaviors, and higher pandemic fatigue. Regarding now the longitudinal study, this study aims to investigate the nature of vaccination hesitancy and its determinants prospectively from January 2021, when a vaccination for COVID-19 was developed, and throughout the vaccination rollout in 5 countries. Specifically, we have 3 objectives. Firstly, we wanted to investigate the determinants of vaccine hesitancy across time points. Secondly, we wanted to identify the patterns of vaccine hesitancy across time points. And finally, to investigate the associations between intentions to vaccinate at the beginning of the study and the actual uptake at the end of the study. So, for the purposes of this longitudinal study, Data Spring Company was recruited for the data collection, and the inclusion criteria for this study were 2: to have adults and residents of these 5 European countries: France, Germany, Italy, Poland, and Spain. We performed a G-power calculation in order to identify the representative sample in each country, and we found that the inclusion of 125 individuals per country could provide a medium effect size. Again, we use REDCap software, and prior to completing the survey, the participants provided informed consent, and also the study was approved by the Cyprus National Bioethics Committee. So, the data collection took place in 3 different measurements. The first measurement was between January and February 2021, and 600 participants per country were included. The second measurement was between May and July 2021, and in this measurement, we included 300 participants per country, while the last measurement was between September to October 2021, and 150 participants per country were included. We have decided to include these participants in each measurement occasion in order to have at the end the representative sample that we wanted to have. The main outcome of this study was the gap between the intention to vaccinate at the first time point of the study and the vaccination behavior status at the end of the study. For that reason, we coded two different binary variables. The first variable was included the individuals who had intention to vaccinate at the beginning of the study and either vaccinated or not at the end, namely acceptors versus hesitant. The second variable included the individuals who had no intention to vaccinate at the beginning and either vaccinated or not at the end, namely convinced versus refusers. So in total, 771 participants from all countries completed the survey at all time points of the study. The mean age of the participants was about 44 years old, with about half of them being females. The majority were engaged or married, lived in an urban area and lived with their own family, and also had underage children. Regarding the vaccination coverage in total, but separately in each country, we can see that at the beginning of the study, the vaccination coverage was only 2%, while this percentage became almost 80% at the end of the study. The largest vaccination coverage was identified in Spain and the smallest in Poland. And maybe it's important to mention that the youngest population of the country was from Poland. So this may play a role in these results. Now, in order to find the determinants of the vaccine hesitancy across time points, we perform a hierarchical multi-level model in order to demonstrate the impact of all the participants' characteristics on vaccine hesitancy across the time points of the study. So as you can see from the graph, we found that as the trust in healthcare professionals and in collective responsibility increased over the time period, the probability of accepting COVID-19 vaccine increased too, while 3 of the 7 items of the 7C scale were also statistically significant, and we found that as complacency, constraints, and conspiracy increased during the time period, the probability of accepting COVID-19 vaccine decreased. After this, we divided the participants into 2 main groups: the participants who had intention to vaccinate at the beginning of the study and the participants who had no intention to vaccinate. We found that 476 participants had intention to vaccinate at the first time point of the study. And from this graph, you can see the statistically significant changes on the determinants of the study in these participants. So we can see that we have decreases during time in complacency, in constraints, in the cognitive risk perception, in the adherence to COVID-19 behaviors, and in the affective risk perception. And we reported increases in the compliance, in the trust in international health organizations, and just this. And after we applied the multi-level model, we didn't find any statistically significant associations between the gap of the intention and the actual behavior status among the participants who had intention to vaccinate. Moving to the participants who had no intention to vaccinate at the first time point of the study, we found 203 participants. And here we found statistically significant changes in complacency, constraints, collective responsibility, compliance, severity, the adherence to COVID-19 behaviors, and in the affective risk perception. Now we applied again a multi-level hierarchical model, and after included all the predictors in the model, we found statistically significant associations among those participants between their intention to vaccinate and the actual vaccination status at the end of the study period in some items of the 7C scale. Specifically, we found that as complacency, conspiracy was increasing over time, the probability of accepting COVID-19 vaccine at the end of the study period decreased. While as calculation was increasing over time, the probability of accepting COVID-19 vaccine increased too. So very briefly about the conclusions for all the individuals, we reported that vaccine hesitancy reduced from the first measurement occasion to the third, and we found that as trust in healthcare professionals and collective responsibility increase across the time point, the probability of accepting the COVID-19 vaccine also increased, while as complacency constraints and conspiracy increase across the time point, the probability of accepting the vaccine decreased. Regarding the two main groups of the study, the individuals who had intention to vaccinate and the individuals who had no intention to vaccinate, we reported statistically significant associations only for the second group, for the individuals who had no intention to vaccinate, and we found that as complacency and conspiracy increased across the study period, the probability of accepting the COVID-19 vaccine decreased, while as calculation increased, the probability of accepting COVID-19 vaccine increased too. Thank you very much for listening, and special thanks to our research collaborators. Thank you very much.
Thank you very much. Thank you, Brianna, for this really extraordinary presentation. The next speaker is Dr. Andrea. The next speaker is Dr. Andrea Christodoulou. Dr. Christodoulou is a school and clinical psychologist, and she's a lecturer in clinical psychology at the psychology department of the European University of Cyprus, and the research assistant at the Cyprus project. Dr. Christodoulou will be presenting the results of a pilot experimental study which used social network interventions to examine the social transmission of attitudes towards childhood vaccination in parental social networks.
Thank you, Christiana. Hello again. I will be presenting the methodology of the experiment. As I will say at the end, the restrictions was increased, so I won't present any results. However, in future, we will be able to present some preliminary findings after we have some other on-the-side alternative experimental study. A little bit about the theoretical framework about social network intervention. Basically, the network intervention programs were used in order to examine the different mechanisms of social networks that they can affect the efficacy or the speed of transmitting vaccination attitudes. Four perspectives were proposed: the individual, the segmentation, the induction, and the alteration. However, only two will be presented and used in the present experimental study. The individual perspective, where we locate centrally positioned members within a social network in order to transmit attitudes to others, which was considered to be the most effective approach. And the second one, the segmentation approach, where cluster group of connected individuals within a social network are identified in order to spread attitudes at a group level, which was also found to be efficient in spreading positive health behaviors. Now, the problem found in the literature, none of the social network intervention studies focused on promoting vaccination attitudes, and especially parental vaccination attitudes. So, as we found in our in one of our study that we did in the SAFEST project, social contacts have a great influence on spreading vaccination attitudes to people. So we believe that applying social network interventions It might help us examine how they can affect the contagion of vaccination attitudes in a social network of parents. So the research objective was to examine the position of a certain person, whether it was a central person or a group of people, on how they will have an impact on how efficiently vaccination attitudes is transmitted. The first hypothesis was that the individual group, the one with the central located people, will have more positive vaccination attitudes compared to the segmentation or the control group. The second hypothesis was that the segmentation group, the cluster of people, the group of like-minded people, will have more positive vaccination attitudes compared to the control group. And the final hypothesis was about maintenance. We believe that individual and segmentation groups will have sustained positive vaccination attitudes at a 3 months follow-up compared to the control group. As for the design and procedure used in the present experiment study, the first part of the study, recruitment, screening, and randomization, was done. Multiple recruitment methods were used. We created an online package questionnaire in order to use it for screening purposes, detecting individuals that were eligible in the present study. Basically, they were parents of at least one child under the age of 12. And they were randomly assigned to 3 experimental groups, the individual, segmentation, and control group. Now, the second part of the study was the network building, because they were unknown to each other, the members of each group. We used the Breadboard software platform in order to create connection within each social network. And basically, parents enter this platform with other users, review their profile, and checked or to connect or not to connect with others based on some friendship criteria, whether they had the children at the same age, whether they were at the same age, whether at the same region, and so on. And at the end of the week, the social network analysis was performed in order to identify each group's members' position. In the first group, we identified the central people. In the second group, we identified a group of like-minded people, the clusters. And in the third group, which was the control group, we identified random position individuals. And in the third part, that was the magic happened, the randomized control trial. At the beginning of the week, the selected members, the ones that were located based on their position, they were trained. They received a single-day training session regarding valid vaccination information. And during the next week, all participants of each group participated in discussion groups, in closed Facebook groups, whereas researchers posted daily information regarding vaccinations, and all members of each group had to respond, comment on that post. And the selected members had to transmit valid information towards the other members of each group in order to affect their opinions and their attitudes. And an online package of questionnaire was completed by the members of each group at the end of the experiment and at a 3 months follow-up. Regarding the measure used, we measured the vaccination hesitancy, the reasons for vaccination hesitancy. We detected the most important values of parents. We detected some demographic information, and we tried to identify through some questions the position of each individual, whether it was a central person or a cluster of people. The statistical plan was to use social network analysis, which was used to identify the centrally positioned individuals, the clusters, and the random participants. And for the main hypothesis, linear mixed models was planned to be used in order to examine all 3 hypotheses. Happy to share, we published our pilot experimental protocol in Health Psychology Bulletin if anyone is interested to read more about this study. However, some restrictions were detected during the experimental study. The low participation rate and the dropout rates was the main restriction. So due to small number of participants in each group, there was an inability to run social networks analysis. So an alternative solution was used. The simulation study was introduced to us in order to examine the contagion of vaccination attitudes in students' now social networks. The plan was to collect data from different university classes of Cyprus and Spain and run then the simulation study. Until now, we have collected data from 5 classes in Cyprus and currently collecting data in Spain. That's why I said before that we have in future some preliminary findings regarding this trial and maybe run some future analysis on the experimental study with the small number of participants we have. Thank you so much. A special thank you again to our collaborators, which are a lot in all of our studies. Thank you very much.
Thank you very much, Professor Dodu, for this stimulating presentation. Now, the next speaker is Ms. Christiana Karachali. Ms. Karachali is a PhD student in clinical psychology at the University of Cyprus, and she is currently working as a research assistant at the Cyprus project. Ms. Karachali will present a qualitative study which explored the mechanisms of social contagion of vaccination uptake in the context of COVID-19 in Cyprus. Ms. Karachali, the floor is yours.
Thank you. Hello, everyone. I'm going to present a qualitative study exploring the social transmissions of beliefs and attitudes of COVID-19 vaccinations in Cyprus. The social contagion refers to the spread of affect, attitude, or behavior from one person to another, and vaccination attitudes and behaviors can spread within networks and be influenced by each individual's social contacts. This theory has been applied in various contexts, such as food choices, obesity, and smoking, and the significant effect of social networks in individuals' attitudes and behaviors was identified in all studies. Regarding vaccinations, parents may hold more positive vaccination attitudes and greater likelihood to get vaccinated or vaccinate their child when they are frequently exposed to positive attitudes and discuss vaccinations with their friends and family. This theory further proposes some mechanisms. For instance, people in a central position within a network may influence attitudes and behaviors to a greater extent than those being in the periphery of a network. The mechanism of exposure says that practices may diffuse within but not between groups. The mechanism of choice homophily highlights individuals' predisposition to interact with culturally similar others. And strength of ties says that individuals share their thoughts and intentions, mainly with those with whom they have enduring relationships and with people that they trust and feel emotionally attached to. Contagion models have been criticized for normally conceiving of cultural transmission as a simple and straightforward process. And however, the perceived value of adopting a cultural practice depends on how we interpret it. So, for example, those exposed to the same information might still behave differently and have different feelings regarding a specific behavior. So instead of taking vaccine hesitancy, rejection, or acceptance as given categories, our aim was to explore the experiences of people, their attitudes towards COVID-19 vaccination, and the motives and factors influencing this. We therefore followed the qualitative approach. And to our knowledge, this is the first project investigating the social contagion of vaccination attitudes to individuals in social networks using this approach. And there is little to no qualitative research focusing on vaccine use in Cyprus generally. So our aim was to understand the mechanisms of social contagion of vaccination uptake in the context of COVID-19 That is, how do people perceive their social network to influence their behavior, and how they perceive their behavior to influence their social networks, attitudes, and behaviors. The primary research question is how and in what ways does the social environment affect an individual's choice to get vaccinated or not? And the secondary research questions are how do people perceive the role of the vaccinations to be, and what are the barriers to COVID-19 vaccine acceptance? So this is a qualitative study drawing on one-to-one interview data. This method allows an understanding of participants' thoughts and feelings in a realistic scenario. And regarding the participants and inclusion criteria, they were 18 years old and above, they were fluent in Greek, and they had the capacity to give informed consent. So this study took place in a quiet room, and participants were given a consent form and an information sheet to read and sign. They were also provided with a socio-demographic questionnaire, which included questions regarding vaccination history. They also received a screening questionnaire, the vaccine hesitancy scale adjusted for adults, which was translated to Greek. And this was mainly used to reassure that the sample involved people who are both hesitant as well as positive towards the vaccines. And the participants were also given an incentive of 20 euros. The interview guide included semi-structured questions, which focused on how participants perceive vaccination's role, what are the factors that make them hesitant to vaccinate, how their environment influences their decisions, and how they influence their environment. The interview schedule was firstly piloted with 3 to 4 people, so we are able to make some early suggestions on the viability of the research. Each interview lasted around 45 minutes, and all data remained confidential. And data were analyzed using thematic analysis, which involves 5 phases: familiarizing with the data, coding generation, looking for themes, reviewing and refining themes, and theme labeling. We used both semantic and Latin codes. A semantic code has to do with the surface meaning, just what the participant is saying, whilst the Latin code explores any assumptions and conceptualizations that are possibly hidden behind the semantic content. The transcripts were inductively coded without aiming to fit them into a pre-existing coding structure or the researchers' preconceived ideas. The codes were grouped into sub-themes, and the sub-themes were then grouped into themes. We had 11 participants, 3 females and 8 males. The age range was 23 to 60 years old. 3 of them had children. They were all Greek Cypriots. Most of them had a bachelor's degree or master's degree. 4 were engaged, married, and 7 were single. The categorization of participants as hesitant, positive, or negative was guided by the way another study categorized the participants, where they adjusted the vaccine hesitancy scale for adults. So 3 were hesitant and vaccinated, 3 had negative views and were unvaccinated, and 5 had positive views and were vaccinated. Regarding the findings and attitudes and perceptions regarding the pandemic and COVID-19 vaccines, whilst for a minority of participants, the pandemic was perceived as a teachable moment to appreciate the simple things, such as spend time for themselves, almost all referred to challenges and difficulties, such as lack of freedom. And because of those challenges, many expressed their desire to return to their normal lives, and thus they perceived the vaccine as a passport to freedom. And almost all, even those who had more positive views, seemed to worry about the long-term effectiveness of the vaccines. And most of them also said that the vaccine is not needed and effective for everyone. For example, older people might need it more than younger people. I've also included a thematic map of the themes and sub-themes, and I'm going to present them now in more detail. So the first theme is the information contagion. So the information that participants received from several sources and the processing they did contributed towards their vaccination decision. And the first sub-theme is media's information source. So many participants use the media, such as websites, as their primary source of information on vaccines. I've also included some example of quotes under each sub-theme. The second one was the trusted sources of information. So after receiving information from the media, they rely on their doctors as a source of knowledge to cross-check the information and stay up to date. And the third one is the level of knowledge. So they highlighted the importance of having a good level of knowledge to be influenced by others, but to also influence other people. And the second theme is a behavioral contagion. That is how others or the vaccination behavior of others had an impact on participants' own vaccination decisions and behaviors. So the first sub-theme is the credible source influences vaccination behavior. So participants follow what the doctors advise them. The second one is the mechanism of choice homophily, where they said that they are exposed to similar attitudes and threats. For example, a participant said that she was influenced by and she influenced a friend of her with whom they are quite similar in many things and have common opinions. The third one is the strength of ties. So they share their thoughts and intentions, mainly with those with whom they have enjoyed relationships and with people that they trust. And the final one is the mechanism of exposure. So vaccination behaviors and preferences may diffuse within groups. For example, they tend to share similar vaccination attitudes and behaviors, they said, with their co-workers. And also a participant said that he decided to receive the vaccine because all of his family members were vaccinated before him. So he had greater exposure to positive vaccination behaviors. And transcending these two themes was the notion of ownership and choice. So whilst the information and the discussions they had motivated them to take specific decisions, this had been undermined by their perceived ability to make their own decisions and their own choices. So the decision-making process was not perceived as being a passive process, and they gave a sense of having a stronger degree of responsibility and agency. For example, a participant said, I would definitely trust the doctor, but the final decision is always mine. So overall, participants were mainly exposed to information from media. Most of them discussed their concerns with the doctors as they trusted them and they said that they are the experts. On the other hand, they said that they do not trust the politicians as they are not experts. They also seem to feel more confident and open to discuss and exchange information with people who have the knowledge and be influenced by them. So there is a need for evidence-informed vaccination decision-making. The behavioral change techniques taxonomy could be used to describe the findings, and it describes a credible source, the present verbal or visual communication from a credible source, such as healthcare professionals, is in favor for or against a behavior. The pros and cons refers to when the person is advised to identify and compare the reasons for wanting or not wanting to change a behavior. And indeed, some mentioned that they weighted the pros and cons with their doctor. Also, they were influenced and they were being influenced by friends and family members with whom they share similar traits and attitudes and have a close relationship of trust and intimacy. Homophily was identified as a significant factor influencing vaccine attitudes, especially in respect to race and ethnicity in a previous scoping review. And this study further highlights homophily in respect to attitudes and beliefs as well. And also being exposed to positive attitudes and beliefs towards the vaccines led many participants to follow that road as well. Regarding implications, policymakers could consider including social networks of individuals when delivering interventions or educational campaigns on vaccinations. And the interventions and campaigns could include the experts, such as doctors, giving the statistics and relevant information. Before closing, I would like to thank the members of the research team and thank you all for listening.
Thank you, Ms. Charlie, for this excellent presentation. The last on the list speaker is Dr. Maria Paraskeva. Dr. Paraskeva has worked as a teaching and research fellow in language and literacy at the Department of Education at the University of Cyprus. Dr. Paraskeva will be presenting a project that has considered the discourses of COVID-19 and the vaccination movement in Cyprus from a sociolinguistic perspective. This project has been funded by the A.G. Leventis Foundation and the Hellenic Observatory at the London School of Economics and Political Science under the A.G. Leventis Research Innovation Program on Cyprus 2021. Dr. Paraskeva, the stage is yours.
Thank you very much, and thank you for allowing me to be with you today. So, as Christiana has said, in this presentation, I will be talking about a project which has considered discourses of COVID-19 anti-vaccination movement in Cyprus, taking insights from speeches in on-site protests. This presentation will include the background, the methodology, the results and conclusions, and some policy recommendations and implications deriving from the project. So, a central manifestation of COVID-19 anti-vaccination sentiments is language and or discourse, mainly considered in the form of anti-vaccination linguistic or discursive trends in the social media. Some relevant studies show that in discussions on COVID-19 vaccine in Reddit, skeptical, aggressive remarks are the predominant topic in anti-vaccination users' comments and concerns. In addition, in discussions in Twitter, anti-vaccination proponents, albeit with fewer tweets, display greater engagement and greater emotional and conspiracy theory-related content as compared to pro-vaccination proponents. Regarding online anti-vaccination discourse in the Greek or Greek Cypriot context, which is very sparsely considered so far, anti-vaccination proponents appear to consider vaccination as a threat for Orthodox Christians and as a means of killing children. In addition, anti-vaccination proponents' anti-Semitic narratives, albeit non-dominant, involve the ideas that a group of powerful Jewish people are orchestrating vaccination for controlling the world, and that unvaccinated are comparable to Jews prosecuted during the World War II. So against this focus on the anti-vaccination movement, language, and or discourse as presented online, this project examines the discourses contained in speeches as articulated in COVID-19 anti-vaccination on-site protests in Cyprus, thereby bridging the gap caused by both the absence of research on the oral discourses articulated in anti-vaccination on-site protests and the very limited consideration of the anti-vaccination discourse in Greek-speaking contexts. The focal points of this project are the main topics included in the speeches, the range of implicit and explicit influences or resources upon which the speeches draw to support their arguments, and third, the linguistic strategies that the speeches contain to persuade the public on certain vaccination or anti-vaccination ideas, and in turn shape the beliefs and knowledge of the public. In terms of methodology, relevant data from different settings during January and February 2022 were collected. These involved attending various anti-vaccination protests and video recording on-site speeches given during these protests, a task which was not that easy to do. The data collection worked backwards as well by searching for and collecting past speeches of anti-vaccination protests available in the social media in the form of shared videos. Overall, 36 speeches of different durations were transcribed and analyzed using a combination of quantitative and qualitative approaches like thematic analysis and critical discourse analysis. And here we can see some photos from the given settings. Turning to the results and conclusions and the main topics included in the speeches, these were found to be four, namely government, governors, politicians, then vaccines, vaccination, vaccinated or unvaccinated, then measures, and children, parents. The main topic of government, governors, politicians was further distinguished into two subtopics, accusing government and appeals demands from government. In a similar vein, vaccines, vaccination, vaccinated, unvaccinated were distinguished into three subtopics, that is questioning the vaccine's efficacy and effectiveness, against vaccination, and the idea of vaccinated people spreading the virus. Measures clustered into two major subtopics, that is being against measures and alternative explanations of measures, and the fourth main topic, children, parents, branched into four subtopics, the est protecting, fighting for children, disapproving child vaccination, disapproving measures in children, and parents being in a difficult situation. Now, a striking finding in relation to the point of being against vaccination identified in both the vaccines, vaccination, vaccinated, unvaccinated, and children, parents topics is that in the former topic, the great majority of instances of objection related to mandatory vaccination, whereas in the latter topic, children, parents, the objections were on vaccination wholesale. This suggests that anti-vaccination supporters are more reluctant to accept vaccines on children than on adults. At the same time, accusing government, governors, politicians was the most frequent subtopic across speeches in terms of number of instances. This indicates that anti-vaccination proponents consider the governing bodies responsible for the situation to which they object, and they can be said to act as an opposition party. With regards to the influence resources on which the speeches are based to support their arguments by means of various intertextuality forms, results show that the most productive sphere was the political one. We can see it in the greater part of the circle, followed by the religious sphere domain, then the social sphere, then the scientific, and finally the historical sphere domain. And these results accord with the findings on the main topics included in the speeches, where the most frequent ones revolved around government, governors, politicians. In relation to the linguistic strategies contained in the speeches, the analysis of the representation of processes via linguistic structures showed that the most significant exclusions from the processes were representations of the vaccine's safety and effectiveness, with speakers selectively drawing upon only those pieces of information, quotations, and reportings that show otherwise. In relation to the representation of social actors, when speakers represented themselves, they only used pronouns and no equivalent nouns at all, contrary to the use of both nouns and pronouns when representing other individuals, groups of individuals, or the governors. This is important because it shows that anti-vaccination proponents opt out of identifying themselves with specific nominals, with specific names, nouns. At the same time, representations included instances of the collective we in referring to the anti-vaccination proponents, that is, in referring to themselves, and the use of abstract you in referring to the governors by and large. This shows that anti-vaccination proponents identify as members of a specific group, the we group, which is distinct from or even opposing to the you group and can be said to afford them a collective identity. Now, let's close this presentation with some policy recommendations and implications. One, the identification of the main topics included in the speeches contributes to the documentation of the current state of the arts in relation to the thematic and argumentative trends of anti-vaccination supporters, as attested in protests in Cyprus. This is very useful for the local government as the most frequent topic in the speeches, and especially because of the accusations towards government made by the anti-vaccination proponents. Then the local governing bodies need to redesign an informed communication plan towards the public in such way that it addresses anti-vaccination proponents' concerns too. Two, local government can consider the documentation of the thematic and argumentative trends of anti-vaccination supporters comparatively with other states or countries in order to identify universal features, thereby establishing cross-country synergies for forming common or parallel plans of action in response to the COVID-19 pandemic, including responses to anti-vaccination proponents. Three, the fact that anti-vaccination supporters seem to be more reluctant to accept vaccines on children than on adults can be addressed by medical doctors, pediatricians, the local epidemiologic team, and health professionals in general, who can deliver jargon-free seminars, workshops, and other informative sessions, especially on the safety of vaccines for children, drawing on results of relevant updated medical and scientific studies. Four, the identification of the range of influences resources of the speeches is very useful in that prominent stakeholders of each of these spheres domains, that is the political, religious, social, scientific, and historical spheres domains, can engage constructively in communicating pro-vaccination messages. And policymakers can invite these prominent stakeholders to participate in targeted campaigns like TV and online spots for enlightening the public and especially the anti-vaccination proponents in relation to the safety of vaccines, thereby affecting change. And five, the analysis of the grammatical composition of the speeches clauses in terms of how processes and social actors are represented provides insights into the perspectives projected or not in the speeches, such as who is represented as causing what to happen, who is represented as doing what to whom. These are significant because they uncover the covered ideologies and power relations of the speakers, which are valuable for policymakers as they can gain a deep understanding of the underlying beliefs and attitudes of anti-vaccination supporters. And policy-relevant stakeholders can hire experts in various sciences for monitoring, analyzing, and reporting anti-vaccination proponents' online and on-site stances and trends, and this will form the basis for preparing responsive material like press releases, fact checks, etc., which will also tackle misinformation, disinformation, and fake news spreads. Thank you very much.
Really interesting and stimulating.
Thank you. My pleasure.
Please stay there and let's keep this come up to the stage. The questions.
Wait, that's it.
Yes, any questions?
Just a second, sorry.
All right. Hello. Guede? Okay. Thank you for the wonderful presentation. All of them. They were excellent. Thank you for sharing your knowledge with us.
Louder, please.
It was louder than this? Okay, great. My name is Eleni Tolma, and I'm former associate professor, College of Public Health, University of Oklahoma, and I just repatriated in Cyprus. So it's great to see all these wonderful presentations about COVID. I have two questions for the first and the second speaker. The first question for the first speaker, she mentioned that the study was part of a randomized control trial. So I was wondering if the students were recruited as part of the control group or the experimental group. That was not clarified in the presentation. And the second question has to do with the survey used in both studies, the first and the second one. Apparently, you have utilized established scales. The survey was already established, but I was wondering if you adapted the scales to the Cypriot culture, whether you've done any translation to Greek or back translation to English, whether you've done any pre-testing, focus groups, any establishment of the psychometric properties of the surveys before you administer the surveys. Thank you.
So for the first presentation, the recruitment was part of the randomized control trial that delivered a values-based intervention combined with messaging gain or loss friend messaging, and it was in the student population. I don't know.
Well, the question was between time 1 and time 2, was there an intervention or not?
Yeah,
there was an intervention.
Point, some of the participants received an intervention. So the eligible participants that received either that did not receive the initial COVID-19 vaccine dose or the booster dose, they received a values-based or gain-framed or loss-framed intervention, and these participants were sent a link in the second phase in the 2 weeks follow-up to see if they received the vaccination at the 2-week follow-up.
Okay, so you can assume that perhaps some of the intervention contributed to the change of their behavior or attitudes, correct?
We are still analyzing the data of the intervention, but it seems there is an effect of a small effect of the intervention because it was very brief. The participants received it online. It was written to see some text on a values-based intervention and received a messaging on vaccination. So we are still analyzing them. So
Okay, thank you.
Thank you.
And the second question.
For the second question, can you repeat?
I understand the survey. I've seen the survey that you're talking about. It's an established survey with the scales are very established. But you used it in Cyprus. So usually when we use, surveys from different country, we translate it in Greek or whatever language, and then we back translate it, and we do some pre-testing to check for cultural sensitivity. We do some focus groups, and things like that. So I was wondering if you've done that step before you administer the survey to the people here. To make sure we check for readability, content validity, all those things.
So the questionnaires were validated in Greek in the first cross-sectional paper, and then in the longitudinal study we did not include Greek population. We have only included population from Cyprus in the cross-sectional study. In the longitudinal study, the data were collected from 5 European countries, so they were validated and were translated with all the procedures, with a backward and forward translation for the cross-sectional paper.
All right, thank you.
Thank you.
So I have two questions. I will start from the second one because it's related. You can't hear me? No? Okay, I have two questions. I will start from the second one because it's related to the last question we heard. So a question I have is why Cyprus was not included in the longitudinal part? So if I understand it well, there was a cross-sectional study with Cyprus included. Then Cyprus was not part of the longitudinal, and also the other related thing is you presented a decreasing sample size, which was not clear. Was this intentional? I think you started with 600, 300, and then it was down to 150. Was it intentional or was it just dropout?
So for the first question, Cyprus was not included because we have recruited Angelos. I think it's better. Angelos will better reply on this question because we recruited a company for collecting the data for the purpose of our study, and
so if I come back to that, so what happened was that after the cross-sectional study, we wanted to represent sample from different countries, but in order to do that, because of the time frames of the grant, we recruited a company that had panel data, but the company had specific restrictions in terms of certain countries, and Cyprus was one of them, so they didn't have access to panel data from Cyprus.
Okay.
And that is why we didn't follow up the Cyprus.
Okay, thank you. And the sample issue?
And for the sample size, all of the countries were instructed to find a representative sample of on the first phase of 600 participants. Then from these 600, the company was instructed to repeat the measurements with 300 participants, and then for 150. So
I think the short answer is that based on the power sample calculation, we wanted to end up in the third time point with at least 150 participants. So what we did, we calculated the dropout rates that we would have. And therefore, that is why you saw that graph saying that at the first time point, we targeted 600 individuals from each country, so that at the third point, we end up with at least 100. Because you're right, that was dropout.
It was dropout. Okay. And a very minor thing, I mean, we could maybe discuss it later because it's a bit technical. I think Penelope was in your presentation. You showed some models where you kept adjusting for factors, and then at some instances, if I remember well, at your very final model, you lost statistical significance, and then you concluded that there was no association. But I noticed that your confidence intervals, as you were including covariates, were widening, but still you had effects there. Still you have estimates that were well above, the one. So was it a complete case analysis? At the final model, you only had people who had data in all these factors, right? Are these the same people that were included in your first model? I mean, if it's too technical, don't worry about it, and we can discuss it later.
Yep.
Yeah, it's because we're running out of time. I think we don't have time for any more questions. It's okay.
Yeah.
So closing this session, obviously the policymakers and the public health authorities will focus on changing behaviors, increasing the feelings of trust and motivation on the being of the population of being vaccinated, considering always the social networks of individuals when they design and deliver interventions on educational campaigns on vaccination. Thank you once again for joining this session and contributing to this session. Thank you all the speakers for all these extraordinary presentations and valuable information that you have with us. Thank you.
Proceed to the next session. I will call Graciano's chair the next session. Yes, so there is a change in the program.
We're going to have to make a change in the program. The next session was made to show you what we said about vaccine readiness. It's all prepared, but because we're running very late, we're going to have to make a switch. We have some people waiting online for the presentation, so we're going to move quickly to the next session. So we're going to have 2 talks, and then very briefly before lunch, if it's better to just show you for 10 minutes what we map and discuss it.
So Maria, can you hear us? Just a second. Maria, we cannot hear you. Just a second, sorry, Maria. Are you muted? No. No.
Ναι, άρα... Όχι, πρέπει να είναι mute.
Maria, are you muted? Can you check? No, she's not muted, so it's the laptop.
Δεν νομίζω. Γιατί...
Can you check your microphone, Maria?
Το...
Είμαστε εντάξει.
Ξανά.
Maria, can you talk?
Yes, can you hear me?
Yes, now we can hear you. Great. So, thank you, Maria, for your patience, and we now proceed with your presentation. So I will say a few words about Maria. Maria is a colleague and friend from University of Cyprus. She's a licensed clinical psychologist and associate professor at the Department of Psychology, and is heading the ACT Healthy Anxiety Disorders and Behavioral Medicine Laboratory. And Maria will be talking to us about the value of vaccination. Thank you, Maria, and the floor is yours.
Thank you. Thank you, everyone. Excellent presentations so far. I'm really sorry I couldn't be with you today. Unfortunately, family issues came up and I couldn't come to Limassol. I hope to have a chance to see all of you soon. Okay, let me jump right in. When we talked about what to present here, we thought of doing something a little bit more interactive. So I'll do a little bit of an exercise with you as well to kind of see in action the value of, to come into contact with values and specifically the value of vaccination. So let's start by saying what values are. Values are what we say our deepest heart's desires. So this is what we tend to stand for, what gives our lives motivation, what gives our lives meaning, what drives us to try to do things, even difficult things, or to achieve things even when there's obstacles in our way. We're not talking here about goals. Goals tend to be things that have an end point. So, for example, a goal will be to get a vaccine. So I can just go get my vaccine, and that's it. That's a goal. The value, though, it's something that never has an ending point. It's a process. So if I value my health, I will always have things to do to help my health and to make my to try and make my health maintain my healthy life or my health. So that's the difference between values and goals. And kind of like to see it in action, I have an exercise here. I want us to play where we call the game of life. So I want all of you, I can't really see you, but and I can't really interact with you that much, but play with me anyway. I want all of you to think about 5 numbers from 1 to 80, 80. And if you have a piece of paper in front of you, I would suggest if it's possible to get a piece of paper where you are at now and a pen, because I'll have another exercise for us to do as well. And I want you to write those 5 numbers down. Do we have them?
I think people are writing down the numbers.
Okay. Thank you for helping out, Angela.
And your eyes in the room.
Thank you.
Yes, I think they're written down.
Excellent. Okay, now I want you to look at this table and I want you to find your numbers and see what your numbers correspond to.
Yes.
Yeah, I apologize. The letters may be a little bit small. I saw you have a big screen though, so I hope that you will be able to see them.
Now it's better. Yeah, yes.
Okay. So let me know when you find your numbers and find what they correspond with.
Do you want me to tell you mine, maybe?
Has everyone written down?
They're writing down their own, yeah.
Okay, okay. Let's give 1 minute. Do we have them?
Yeah, more or less.
Okay, great. So now I want you all to reflect on what you found. Did you find love or happiness or destruction or, losing everything and having to depend on others, being cheated or being a failure? What did you find? And look at these different adjectives or descriptions that you found here. And I want you to consider a lot of what I've put up here are either values or the things people say they wouldn't value or don't want in their lives. And some of them came from some research that we did, part of the project that Penelope presented earlier, where we looked at, we examined values behind vaccination are in here in this table as well. So what did you find? And would you want, if I said that your life would be based on these values, these 5 values that you randomly picked from this table before you even knew what they were, would you want your life to be like this? I hope most of you would have said that you wouldn't want your life to be like this, that you would want to be the ones choosing how you want your life to be the ones that you would choose from the table to be your guiding principles in life and how your life would unfold from here on out. Right? Angela, are people shaking their heads or agreeing with me?
Yes. At least I had rejected, so I don't want to live rejected for my whole life, to be honest. So, yeah.
Okay, so now I would invite all of you to look at the table again and see if you can find the 5 things, the 5 values that are most important for you. And if you want, you can link this to vaccination, make it more specific and say, I hope all of you have been vaccinated. And if you have been vaccinated, what, or even if you have not been vaccinated, like what are these values that drove you to your decision of becoming or not becoming vaccinated? And write those down. How are we doing? Yeah, well. Would anyone like to share? Anyone, any volunteer can bring the microphone if you like. No? Okay, I can tell you what I put. I put 4, I'm not done yet, but I put healthy, of course. Health is important for me, education for life, change the world, even if it's a little bit difficult, traveling, and I was looking being a good parent, but I didn't find it, so. Okay, but that's a value you have, and you can definitely. One of mine, yeah, extra. Yes, that's fine, and you can add yours. I just put some indicative ones here, but you can add your own, of course. Yeah. So thank you, Angelos, and these are indeed values that drive us in life and probably are related to our decision of becoming or not becoming vaccinated. So these are not goals, so it's not something that we can achieve. So education, you mentioned, Angele, or being a good parent. So you can't say that, you know what, I finished my degree, I'm educated now, there's nothing more ever to learn again. Or I was a good parent today, you know, I don't have to do anything ever again. So there's always more that you can do to be a good parent. There's always more that you can learn and get educated on. So this is a process and kind of like a path to life. So to extend this a little bit further, I want us to do another exercise where, first of all, I want you to think about if you've ever been to like a big store or like a mall, or I know IKEA, I'm not advertising for them, but you may have seen a map where it says that you are here, and it kind of like guides you as to where you're going in that store or in that mall. Well, I want you to think about that in terms of your life. So you are here at this very moment, and in this circle that you see on your screen, and you have a choice. Which direction are you going to take in life? Are you going to take the direction towards your values, these things that we just explored a minute ago, or away from your values? And there's one more dimension here, this dimension with dotted lines that I put here to explore this further as to how to make this choice. And the top part has to do with our inner thoughts and feelings, what comes to our mind, or what happens inside of us that other people cannot really see, and our outer actions. These are things that actually other people can notice us doing. So if we split this kind of like diagram in terms of the one side being towards our values or what's important to us, the other side being away, and then this up-down in terms of our inner world and then our outer actions. And I want to see each one of these quadrants separately, and I want to invite you to In each one of these quadrants, I'm going to ask a question. And I want you to consider what you would answer in each of these questions, especially as it's related to vaccination. So what matters most to me? Here is what we have started doing in the previous exercise. So to consider our values, our needs, our overarching purposes in life. So what's important to me? And that's something internal. It's not something that others will immediately know I have in my mind or in my heart kind of thing. So what matters to me most? And I would invite you to write in this quadrant these 5 or more things that you've already explored. I hope people are writing some things down.
Yeah, some of them, not all.
Okay. And this is what we call valuing. So what matters most to us. The next aspect, the next question I want to pose is, if I were really living in line with what matters to me, what would I be doing? What would other people see me do if I live in accordance to my values? So please write a few things down here as well in this quadrant. Angela, can you tell me when people are done?
Are we done? Do you need a volunteer or?
Not necessarily,
no? Okay.
Because this is a personal kind of
people are
exploration.
done. Yeah, of course.
Yeah, I wouldn't want,
Sure.
I mean, especially given that I'm not there in person, I don't want to put anyone on the spot.
Okay.
So this is what we would call engaging in life and doing what matters. Now, coming on the other side of the away from our values side, and exploring kind of like what happens in terms of away internally that keeps me from engaging in these activities that I wrote on the side of the 2 words. What thoughts and feelings might show up to get in the way of me moving towards my values? So what are sorts of thoughts or feelings or internal kind of obstacles that get in the way? This could be some of the things that you explored with, I think, Dr. Middleton this morning, like maybe fear or, some of these other barriers to getting vaccinated. And this we would call distressing thoughts and feelings, internal struggles. And then if I go down to the last quadrant, what do I do to move away from distressing thoughts and feelings? What sort of actions do I take to not have the thoughts and the feelings, to try not to engage with those thoughts and feelings? And I want you to also consider, does this work, especially in the long run? Is this a workable solution? What you're doing to move away from your internal struggles, from your internal thoughts, feelings, and so on. Angela, can you help me if people have it?
Yeah, they're considering. Yeah, as far as I can say, I don't. So I think we can move on. Yeah.
Okay, so this is what we would call avoiding our internal kind of thoughts and feelings and engaging in actions so as to try to not have them. But what we notice a lot of times is that even if these techniques work in the short run to make us temporarily feel better or, get the stress to go away, we know that long term, this can have detrimental effects both to our physical and our psychological health. So what I want to get to is that each moment is one such choice moment where you can choose which of the two directions are you going to take. Are you going to move towards your values or are you going to move away? Are you going to move towards taking what your mind and what the kind of like red side of my diagram is doing along and engaging in life so as to live the life that you want to live based on what you value and what's important to you. So, and how does vaccination fit into all this? Based on relational frame theory, this is a theory of language and cognition, we know that individuals learn in life by connecting different aspects of things. So connecting what's kind of like what's important. So, and we know that to change human behavior, it's in significant and sustainable ways, we need to scientifically, Angela, are you seeing my slides okay?
Yes, we do.
Okay.
This is a little bit blurry, but I don't know why. I think if you can. Oh no! If you this is.
I don't know. I don't know. It's doing something and moving me from screen to screen. I don't know if it was moving for you as well.
It did, yeah. So, do you have another slide after this?
No, I finished here, but let me
okay.
try and get through this. So right now, what are you seeing? Are you seeing my slide?
We do, but we also see your notes as well.
You see my notes as well. Okay. Okay. I don't know why it was moving back and forth. I apologize. Okay. So in order to change then behavior in sustainable ways, we need to be able to make connections with the world around us. So relational frame theory helps us understand how this learning occurs. So in terms of vaccination, we know that if we connect certain attitudes, certain aspects to vaccination, we may be more likely or less likely to get vaccinated. So, for example, if I learned in life that, I had a bad experience or somebody was telling me that dogs are bad, they bite, then I would start developing this fear of dogs and I wouldn't want to go near them. Similar to vaccination, if people or the media or whoever I'm interacting with is giving me all this information that vaccinations are bad and are going to cause certain, detrimental things to happen to myself or my health, then I may be afraid of getting vaccinated or vaccinating my children. So relational frame theory can explain a little bit how we learn and then impact our vaccination type behavior. We also know that all humans and also animals, we like to follow certain rules. And that makes our life a little bit more predictable or controllable when we follow certain rules. So same thing happens here if we kind of like form a rule around vaccination, so vaccines are bad or vaccines are good, then we would be more inclined to follow that rule that we've set up. So that's something, again, that we need to consider when exploring vaccination, to see what sort of rules has this person developed, and then how can we overcome this. So some ideas here based on research from contextual behavior science and health psychology shows that to overcome some of these frames that we've built and this rule following, inflexible rule following that may have occurred, is to establish credibility in terms of the messages that we give. So you need a credible source of information. This could be a credible speaker and so on, or the information has to seem credible. And this is, before somebody mentioned conspiracy theories, and this is what a lot of what we have seen conspiracy theories do. Present information as if it's a credible source, when in reality they may not be based in real science, or maybe based in pseudoscience, or partly in science, or misinterpreting a lot of times the science. The next one is delivering appropriate consequences. We know that behavior is affected by the consequences that followed, and behavior that is reinforced, so the consequences are reinforcing, is more likely to occur in the future. But if the behavior is punished and the consequences are punishing, then the behavior is not likely to happen again in the future. So we need to deliver appropriate consequences when we want to enhance the behavior. We want to reinforce it so that it continues. We also want to make sense and increase our consumers' perceived self-efficacy. If people believe they can do it and this is important to them and linked to who they are and how they behave, they're more likely to engage in the behavior. The next one is facilitate transition into habitual behavior. So we want this to become part of the person's habits, part of what the person does in life, and the different behaviors they engage in. So, for example, individuals, I've been discussing recently with individuals who are getting their flu vaccine during this time, and if the doctor has them on the list and they always know that in October, November, I get my vaccination, my flu vaccine, they're more likely to have this habit of getting their vaccine each year compared to people that don't have this built into their habitual behavior. Establish appropriate motivative augmentals. And here we're talking about connecting any behavior with why it's important for us to do it. So despite all we think and feel or hear from others, what is important for us to do? So how do we move into the towards section, and how do we move and engage with what matters to us, our values? And I think this is all I had today. Thank you very much. And I would like to thank everyone who contributed to this project. And I also would like to invite you all this coming up summer, we're going to host our Association for Contextual Behavior Science Conference here in Cyprus. And we're very excited about this. So if you care about any of the aspects you've heard today, there's a lot more that are going to be presented, I hope, at the conference, and hope to see you there. Thank you.
Thank you very much, Maria. I'm aware of the time. We're very much behind, so I don't know if there are any questions now. I'm sure you also, as far as I know, you also need to go. So I'd like to thank you once again for the time. I know you had parenting commitments, and it was really important to have you with us. So thank you, Maria.
Thank you very much, and people can reach out to me if they have questions anytime.
Of course. Thank you.
All the best. Bye.
Bye. Thank you. Moving forward, I would like to invite now Dr. Alexandros Iraklidis, who was actually a lifesaver at the last moment because we had a change in the schedule. Alexander is an associate professor of epidemiology and public health at the European University of Cyprus. Alexander, you want to? Yeah. Yeah. Πρέπει να μπει κάποιο USB πάνω. Λογικά ναι, εδώ κάνουμε εδώ τα νομίζω πρέπει να ναι. Οκ. Την παρουσίαση. Νομίζω που γράφει final. Σωστά. Και αυτό του βάζεις από πάνω στα
Okay, so thank you. Thanks again for the organizers, Angelos, Nikos, Urania, Christiana, for inviting me. I will be brief. I know the time is progressing. Anyway, this was kind of a last-minute invitation, so to be honest, I had to expand on a much, much shorter presentation. So I did expand, but still it is short. It's shorter than the rest. So as you can see, we will talk about some kind of behavioral and psychological concepts potentially related to vaccine hesitancy. So I'm sure by today you have heard many times about vaccine hesitancy, refusal, why they are important. But the way I like to show it is with actual numbers, and I'm using numbers here from the European Union. So you can see here the time after the first vaccines, where we had the first vaccine rollout. If you remember, it was January 2021, and obviously coverage or uptake was down to 0, and then as the months progressed, we went to 20%. At 6 months, that is EU level, okay? By 9 months, we reached 60% people vaccinated in the EU, and then the interesting things started happening. You would expect this, if there was no vaccine hesitancy, to shoot up there, but you can see 3 months later, at 1 year, we are just up to 70%. And actually, 1 year passed and we were +3, so just 73%. So it's quite clear that we are seeing here a hesitation of the public in getting vaccinated. Of course, a lot of people did, but the interesting thing to be aware of is that someone might say, yeah, but there were logistical obstacles and governments were not ready to vaccinate all of these people. Yes, but we know from research that at least the developed countries of Europe, if we're talking about Europe, by 9 months were almost all of them in a position to vaccinate their whole adult population. And you can see that from there on, we had a clear phenomenon of vaccine refusal. Okay, so it is definitely an issue that we need to worry about and an issue that we need to tackle. Why is that? In this period where actually we could have ended the pandemic after 9 months, a year, if we had 90% vaccination coverage and above, we had, I remind you, about 60. Since that time, this prolongation of the pandemic in the EU alone resulted in an estimated of 360,000 people dying from COVID, let alone the morbidity and of course the huge healthcare costs. So we thought at the European University Cyprus that this is something that we definitely need to investigate. To be honest, I'm not coming from the field of infectious disease epidemiology as other colleagues here are coming, but definitely this is something that I was really interested personally to investigate. And just to add on what I was saying, that still today there is a very small number of people that got the full vaccination regime available, and in fact, again in the EU, about 8% now only 8% has received the booster dose. Now, you might be thinking that the pandemic is over. It might be over as we knew it, but still, this is something that needs a lot of investigation, because we don't know how the pandemic will progress, and we might have future pandemics. If not pandemics, definitely epidemics. So, what we sought to do, we decided to, as other people here, we decided to investigate determinants of this phenomenon of vaccine hesitancy and refusal. Definitely there are. We know some of them we don't. So in this presentation, I will be concentrating on 3 of them. Doesn't mean that they are the only 3 or that they are the most important. We believe that they are important. We have investigated other things as well, but these form a nice kind of group of determinants. So I'm talking about health literacy, health consciousness, and health locus of control. You might be familiar with some of these. I'm pretty sure with health literacy, maybe health consciousness. The third factor might not be very familiar, but of course, I will explain what these are. Now, for health literacy, we all know what health literacy briefly is basically the ability or the skills to be able to find, understand, and use health-related information and services. It is a predictor of health behaviors, for example, diet, physical activity, smoking, alcohol consumption, based on research. It is modifiable, and we care about this, as we will see at the end. And it has been linked, as we saw before, it has been linked to vaccine hesitancy. Now, what is health consciousness and how it differs from literacy? Some people might be thinking, isn't this the same thing? It's similar, but it's not exactly the same, because consciousness has to do more about kind of an internal drive, a willingness to be healthy, to care about one's health, and as I said, a drive of following health-promoting behaviors as the person understands them, of course, and that's important. It has also been linked to health behaviors. It is not so easily modifiable as health literacy, and its link to vaccine hesitancy is not clear at all. There are very few studies that have investigated this. And the final component, locus of control. Now, this is an interesting concept. Again, it's kind of related to the other 2, but it has to do with how people perceive their control over their health. It's coming from the psychological literature. The overall concept is basically how much control you have on your life, but if you put this on a health context, basically it means how much control you feel you have on your health. And of course, there is what we call internal health locus of control, where people think that they have control of their health, and there is external health locus of control, which splits into 2 components. We'll see that in a while. External locus of control means that people feel that they don't control their own health. Their health is determined by other factors. Which factors? We will see in a while. So I will introduce a small cross-sectional study we did. It's not that small. It's a bit bigger than that, but these are preliminary data. We're now about 500 people or more. This is a preliminary sample. These are the data that we have analyzed so far. We used proportional quota sampling, trying to make a good representative sample. Of course, it's difficult if you are not following, random methods of sampling. That was really difficult to do while we had the pandemic. You can see some basic characteristics of our sample. Did we achieve a representative sample? Kind of. Surely when we were collecting the bigger sample, we were closer to the representation of the general population of Cyprus and Greece, the two countries that we included in our survey. So 44% men, so women are slightly overrepresented. Urban areas are overrepresented for sure, and this is one of it is probably the one factor that makes our sample not so representative. But as I said, in the bigger sample that I'm not showing here, we have kind of fixed for that as much as possible. Of course, we have a mixture of marital status categories. Some people are single, married, cohabiting. I didn't mention the age range from 20 to 81 years of age, so we had all of the range of adulthood. And a good representation of educational attainment. So we had people from secondary school, colleges, higher education, undergraduate, postgraduate. So it was a good kind of representation there, and the income obviously as well. Income categories, these are kind of grouped together. We had more detailed categorization. So moving into how we have assessed these factors, obviously there are validated questionnaires, and the majority of these are standardized in the Greek language. Just to address a point mentioned earlier, so the health literacy scale was translated and used in Greek before by Nikos and his colleagues. Also, the multidimensional health locus of control has been translated and used in Greek, and we had to translate the health consciousness scale G, and we are in the process of validating this in the Greek language. Main outcomes, obviously, an obvious outcome is whether people were vaccinated or not, and how many doses they had. And another outcome that we decided to basically derive is what we call the COVID-19 vaccine, the COVID-19 vaccine hesitancy scale. So essentially this takes into consideration how many doses people received. So obviously it's one thing to measure vaccine hesitancy in a non-pandemic, let's say, situation, and it's another thing to assess it in a pandemic situation. So whether someone has been vaccinated or not and how many doses they did, this of course needs to be taken into consideration when you want to assess vaccine hesitancy. Other factors that we actually consider when compiling this hesitancy scale, I repeat, this is specific for COVID-19, was whether there was an initial intention by people to get vaccinated. As you know, a lot of people were vaccinated without wanting to be vaccinated because they had to do it, because they would be fired from work, because they were afraid that they would transmit the virus to a close person that they love. So there are different reasons. So it was important for us to assess the initial willingness of people on a Likert scale. Another factor was how they felt after they got vaccinated, not talking about side effects, but whether they were satisfied with what they did or whether they hated, let's say, the two extremes. I'm giving now, hated the fact that they had to get vaccinated, and what was their intention for vaccination on the long run. For example, now we see that the pandemic is in a very, very different stage. When we're collecting our data, there were discussions that one way of containing the pandemic, managing the pandemic, was to proceed with a kind of a long-term vaccination, maybe once a year. That would be universal for everyone. So we ask this question, and based on people's answer, again on a Likert scale, definitely I will be vaccinating long-term, or definitely not. Again, we consider that in this vaccine hesitancy scale. So moving on to our statistical analysis, obviously, if you want to find determinants of outcomes, you need to use regression. So for our binary outcome, vaccine refusal, we used multiple logistic regression. For our scale, the vaccine hesitancy scale we created, we have used linear regression, of course, adjusting for potential confounders, demographic factors, and some socioeconomic characteristics. So let's see what we found in this preliminary sample. First of all, I'm showing the proportion of people who were vaccinated or not, and you can see that we had 15% of people that received no doses at all. And I need to stress here that this study was towards the end of the pandemic. Actually, the plan was to still recruit people, but for other reasons, we decided not to continue. But still, after, let's say, almost 1.5 years after the vaccines were out, in our sample, we had 15% people not receiving any doses at all. And this is a distribution of this COVID-19 vaccine hesitancy scale. You see something interesting. It has definitely a skewed distribution. A lot of people are non-hesitant. These are the people that got vaccinated and were feeling pretty good about it. And the frequency then was declining as hesitancy was increasing. And then we had this interesting phenomenon here that we had a good proportion of people that were really, really hesitant. You might call them anti-vaxxers, or you can put any label you like. We call them the really hesitant people in our study. So let's see the main findings here, what we found as far as associations are concerned. And I need to stress here, I mentioned it before, you see the different scales here. What I didn't mention, and is good mentioning now, is that the locus of control scale splits into 3 subscales, and we have confirmed this with factor analysis. One subscale is what we call, as I said before, internal locus of control. It's a scale on its own. The higher it is, the higher the score of individuals, the higher the perception that they have control over their health. The health professional locus of control is a scale where the higher the scale is, the higher is the perception that people's health is determined by health professionals, by doctors, by nurses, and so on. And the chance locus of control, the higher the score, the higher people believe that their health is determined by chance, by fate. Let's see, in Greek, mira, grafto. These are the terms that were included in the questionnaire. So what we can see here, as we expected, health literacy, and this, you can see these are odds ratios. So you can see a clear association with health literacy. So for every 1 standard deviation increase in the health literacy scale, we had a reduction of about 30% in the likelihood of not being vaccinated. So clear association, statistically significant. We don't see the same for health consciousness, and that is quite interesting. We can discuss it a bit at the end. It's marginally significant. So the upper confidence interval is actually 1 there. Now, internal locus of control, same direction as health literacy. The higher you feel that you have control over your health, the less likely it is that you will be hesitant to vaccination. And also, health professionals' locus of control, the higher that perception of your health being determined by health professionals, the more likely you are to get vaccinated. And as expected, as we said here, chance locus of control, people who are scoring high on this scale were much more likely not to get vaccinated. So as we said, it's a different thing to assess the outcome of refusal or not, and it's a different thing to actually assess the hesitancy scale. We said clearly that doesn't mean that people who are not vaccinated, okay, are not hesitant. So we repeat the same analysis, this time having as outcome the vaccine hesitancy scale. This is linear regression. You see here standardized betas, regression coefficients, and we see exactly the same pattern. Okay, so these factors, we conclude that they are clear. Just giving some notes here on the interpretation of the plot. Our conclusions, we found from this analysis that health literacy and basically having an internal locus of control are kind of protecting against this perception of vaccine hesitancy and refusing to vaccinate. Of course, we said believing in chance and fate as regards to your health, it seems to be quite strongly linked to higher hesitancy. And health consciousness, that was an interesting thing. Health consciousness, in our study at least, was not so much linked to vaccine hesitancy. And we did observe, and at least the way I see it, still we will investigate it a bit more. The main reason is that there were people who were highly vaccine hesitant that were actually also health conscious. Okay, they were scoring high on the health consciousness scale, but they were not vaccinating. We can think of why. It has to do with their perceptions. It has to do with health literacy. Okay, it doesn't mean that if you are health conscious and you want to be healthy, that you are doing the right things to be healthy. In this case, they were not doing the right thing to be healthy, but they were still health conscious. So in this, for this reason, we didn't observe any,
Sorry for interrupting, just
the time, 2 minutes, 2 minutes. So conclusions, we did mention the global burden. So I will actually close by saying that we all say that yes, health literacy needs to be improved, etc. Our perception is that this needs to happen in schools. It's very difficult to try to improve health literacy in an adult population. It can be done, but if it's included in the curriculum in schools, definitely this will make a huge impact. And of course, we are not talking only about communicable diseases. These approaches will also aid in health promotion and also reducing the risk of chronic diseases as well. And I would like to thank you for your attention.
Very interesting, and I hope you'll be around for people to ask questions.
Yes.
So moving forward, moving forward with Nicholas and the next session.
Angela, please, if you can connect to Matis.
Yes.
So that we can do this very quickly. I know we should have been half the way through lunch already. You're giving me the hardest task. I'm not the kind of person that can adapt very easily. I like to speak a lot, but I will make my best effort to finish this in 10 minutes. No, I don't think so.
No.
I'm sure a lot of you are wondering why we're not just canceling it and moving on to lunch. And there is two reasons for this. A, I'm sure you would all like to see what our collective intelligence suggested this morning about vaccine readiness. And more importantly, we have somebody in Germany waiting for us with about an hour and a half delay, that he is keen to see what we have to show him and discuss it.
Nico, but this was anyway listening to the live stream.
Okay.
And we can use Zoom so he can present, but I'll send him an email.
Maybe he gave up waiting. All right. Oh no, he's here. Okay. All right, let's find the quick way to do this. Can I please share my screen? It doesn't seem to. It's joining. Entire screen window. Hi, Matis. Hi there. How are you? We're very sorry for this. We are running at least 40 minutes late, and we had to move the session. I expect you can hear me. Yes, we can't hear you. All right. Until we solve that issue, I promised everyone 10 minutes, but I'm going to spend 5 solving technical issues.
Πρέπει να βάλω το μικρόφωνο αυτό εδώ για να ακούγεται στην αρχή.
Okay. Μπορούμε να κάνουμε share το PowerPoint γιατί δεν το βλέπω.
Στο host. Στο είναι host να κάνετε share.
Matis, just give us 1 minute.
Please, you muted.
Are you muted? No. No, you're not. Ούτε το share το βρίσκω. Okay, so until we solve the technical issues, let me say that, let me thank everyone for their presentations. It's obvious that we are amongst an academic and research group with a lot of the discussion was about methodology and what we've done right, what we could have done better, and what do our results mean in terms of the validity of our findings. And it should be like that because we are an academic community. But I'm sure there's a lot of interesting discussions to be had over lunch about the concepts that we presented, that all our speakers presented. Please take the opportunity over lunch to discuss. And I'm hoping that I'm going to give you the chance to remember all these concepts because you said these concepts yourself before we even heard any of these presentations.
Can you speak, Mr. Matis?
Hi, can you hear me? Good.
Yeah, that's great. Και κάνω share και την οθόνη.
Ωραία. Matis, I expect you can see my screen.
I can, thank you very much.
That's great. So, you know what we've done this morning. We already had a conversation about it previously to prepare. So we asked our audience, first of all, a quick profile. We are an academic group, at least predominantly. So let's move on. We asked this group why, on the topic of childhood vaccination, why do they think some parents are hesitant towards routine children's vaccines before we even got into COVID? And they had to give a couple of words, short phrases, and this is the cloud that we produced. So, because we're running out of time, I'm going to show you how we classified this into the 7C model. Everybody knows the 7C model now. They've heard it so many times. But because we're running out of time, I would kindly ask you to take my lead and just discuss a couple of points that I'm going to give rather than the whole thing, or at least start from those. First point, we managed to actually map all 7 Cs. So people have suggested something along the all 7. As we previously discussed, a lot of the concepts that were heard this morning in the presentations, our audience suggested them as well as determinants of vaccine hesitancy, but we kind of think of them as antecedents or the context in which people make decisions about vaccination. And I'm referring to health literacy, I'm referring to climate with social influences, political influences, good or not good information coming from all sort of sources. And of course, we are people. So there's personal characteristics, our background, our education, our religion. That is the one point I want you to comment on. We said we're going to pick out things that might be different from elsewhere. It was very interesting that religion came up quite a lot. And we're not even talking about COVID vaccine. We're talking about childhood vaccinations at the moment. So in terms of religion, as you can see, we think it belongs to, it's a personal attribute. It's a personal, that's a personal level. But we also wonder whether you could put it, you would associate it with any of the 7 Cs, especially when it was presented in some comments as religious unwritten law compliance. I have to comply with what I think my church suggests. Is it, it's not compliance to the law, but it's compliance in some other sense. In terms of the cloud, things that came up with childhood vaccines very strongly was obviously side effects, fear, autism was there, possible long-term effects. We had an interestingly, collective responsibility. Some people said taking advantage of herd immunity, so piggybacking. Other people are vaccinated. I don't need to vaccinate my children. Complacency, these diseases are don't pose risk. We prefer natural remedies and so on. In terms of trust, there was mention of trust of science and medicine. Okay? So please keep in mind the issue of religion and collective responsibility, piggybacking in terms of children vaccines. Keep trust, but in science and medicine. And to keep this short, I'm going to show you what happens when we do this again for COVID. And so those 3 points that I said are important. When we did it again for COVID, some things were similar. Of course, we get a lot of confidence. Side effects, it was very quick, it was new vaccine technology, still experimental, so on. But all of a sudden, trust is not just about trust in science. It's very obviously about trust in government, trust in healthcare professionals, trust in the source of the information. Of course, big fonts about conspiracy, misinformation, fake news, they're all over the media, and so on, that we also get for children's vaccines. In terms of collective responsibility, I am amazed to the extent that I'm shocked that our collective intelligence did not put it on the map when it comes to COVID-19, even though it's on the map for children's vaccines. And the reason I'm saying this, and we would like your perspective on this, is that throughout the world, at least in Europe, a lot of governments follow the pro-social approach. We do it not just to protect ourselves, we do it to protect others. That was a message everywhere. Yet, we don't see that some people didn't vaccinate because they might have a low sense of collective responsibility. It's not on the map here, and we would like comment on that as well. Also, I would like you to see that we again fitted 6 out of the 7 C's. Complacency, I'm not in danger, I prefer natural remedies. Constraints were mainly about leave us alone, a lot of pandemic fatigue. Calculation was there. Compliance, and that's another thing I would like you to comment on. We had words like a lot of pressure, they want to make it mandatory, and I have freedom of choice. There was the word anarchy there, so obviously some people think that people that didn't get vaccinated, it was a chance to show anarchy towards others that wanted them to vaccinate. And interestingly, because I think it matches one of our presentations with the qualitative results, we didn't know where to put it. We put it in compliance. Healthcare providers' own views, in the sense that there was doctors telling people they shouldn't vaccinate. And in some way, I don't know where it goes, but I see it as compliance to an authority. My doctor, who he or she herself said I shouldn't get vaccinated for COVID-19, The reference I was making to the qualitative study, thank you, Christiana, for that presentation, was, and one of the main themes was that who has the ownership of the decision, me or my doctor? And one quote was, it's me, but I will listen to what my doctor says. Thank you very much. I'm sorry I've done this very, very quickly. And instead of back and forth, I would like you, I hope you kept notes. I would like you to comment on any of the stuff I said. And let's close this so that we can see you. Hope I wasn't talking on my own. Oh, I was talking to you. Hi. Sorry, did I go too fast? It's just I'm very aware of the time. Can't hear you again. Give me a minute. 1 minute. We go here. Try again.
No? Can you hear us now?
If that's too complicated, I'm just going to talk. That's fine for me too.
All right, great. Now we can hear you.
Okay, good. Wonderful. Just like very, very quickly, why I think such an exercise is very important. So, before I start, thank you very much for inviting me. It has been wonderful talk. I won't talk too long. I know you guys must be hungry. I'll do it quick. Why I think this is important, and especially why I love such exercises as you did. It is because, you're all familiar with vaccination research, and you probably know that in the past people were mostly focusing on confidence when it comes to reasons why people take vaccines or not, which is very relevant because together with the accessibility of vaccines, that's the important factor determining a vaccination rate in a society. What you did is the same that we did when we started with the 5C and then the 7C. It's just like generating ideas and reasons why people take up vaccines or not. And a technique like you did it today is one of the ways to get intelligence about it, which is why I love it. What we did in the past with going beyond hesitancy is that, first of all, we wanted to reframe things in a more positive sense, because it sometimes helps understanding it better. We wanted to go beyond just confidence and include more factors, which is like, for example, societal factors, individual reasoning beyond confidence, but also structural factors that should be included. So this is like what we come up. You all know the 7C. I'm not going to repeat it too much. I just want to highlight that there is more than just the individual reasoning, and that's also what you came up with. I'm going to go on and talk about that in a second when it comes to compliance, for example, or religion, and so on. And this is important to consider those extra things, because the reasons to get vaccinated are not as stable as personality factors, for example, or other things in psychology. It's things that change over time. So this is, for example, data from Germany, from the Cosmo survey, where we have the 5C every few weeks, and you can see all the time there is a lot of change happening. And I think that is very, very important. That's, I think, what can be highlighted based on the word clouds you generated. Things also differ across different situations. They differ across different countries and so on. So let me talk about what you asked me to talk about, and what I also actually find very interesting. You were mentioning religion, you were mentioning compliance, which might be related to religion or not. And you were mentioning a lack of collective responsibility, for example, when it came to COVID. That is very interesting because, again, from also a cultural differences perspective, that is very similar to what we in Germany had before COVID. Nobody here was considering the collective responsibility aspect of flu vaccines, for example. That's why flu vaccination rates were terribly low. And then people started to realize that there is a collective responsibility factor during the COVID-19 pandemic, but only because there had been campaigns. And trust me, if there had been no campaigns with like little ads on TV saying, well, you can also help others. There is people who can vaccinate. That's why you should go. if that was not done, then people would not have considered collective responsibility as a factor. So I'm not sure how the campaigns in Cyprus went. Maybe they did not stress that enough. Because I think in many, many societies, this is not a standard to consider. However, interestingly, in some societies it is. So I've been working with people in Japan, and like in the Western part, collective responsibility as an idea to increase vaccination intentions was more of a new thing in the last 10, 15 years. In Japan and farther east, it has been standard and normal because people wear masks all the time already before the pandemic, for example. So people have been considering that already. So this is one example where you see there are differences, and it's always really important to consider the local cultural context when you start your interventions. Very similar goes for religion. It's very interesting that that came up very much as a reasoning here. In Germany, for example, it doesn't play a big role. And I know, for example, if you go to North Europe, like Denmark, we have a lot of data from there, but all the other Scandinavian countries, for example, they have a very low rate of religiosity in general, and it doesn't play a role there. In states where religion plays a bigger role, yes, religion takes over a role like the state, because it commands and it gives out rules and gives out morals on what to do. And that's when religion becomes part of compliance. So in our considerations, we would not have considered it because when state and church, for example, are clearly separated, it is different things. But we, for example, also conducted studies in Nigeria, where we have some parts where there's very Christian societies, and then we have some parts with very Muslim societies. And vaccination intentions differ in terms of the different societies, also within religions, because it's very often religious leaders promoting whether people should get vaccinated or should not get vaccinated. And they do play a big role, and they do, for example, have an influence in a compliance way when they say, well, you can't come to the mass if you're not vaccinated, for example. So absolutely, I think that plays a big role. And then when talking about compliance, I think that is very interesting, because for us, that had been very much the one important factor or construct coming up during the COVID-19 pandemic. Before, there had been cases where compliance played a role. Let's say, for example, when measles outbreaks in kindergartens here and there happened in different states. There was big cases in the US, there were cases in Europe, and there was some regulation. But before, it was not very much considered before the COVID-19 pandemic, and that's why I think it's interesting that it also came up here again, especially in the COVID cluster. Because compliance plays a role, because if you implement regulations in order to fight a pandemic, for example, people might get reactant because they don't like what you are doing. So you would like to know how people would react. Are they very anarchist people, for example, and just don't like regulation at all? Is that effective? So yes, wonderful that that came up. And then as a final word, let me say, yes, there is a lot of those antecedents that you listed, and I fully agree. Not everything is part of the 7C, but many of those things that you named in the word clouds are actually predictors of the 7C, and they can inform us how we can change the 7C in order to increase vaccination readiness and then vaccination uptake. So all of those things tell us what we can do in terms of intervention. So if we want to have more confidence, we can have more trustworthy people communicate, which I loved in a presentation from our Portuguese colleague, for example, who presented local and small influencers as communicating persons. If we want to reduce complacency, we can increase health literacy. We can teach people that the disease is very terrible, for example, it's dangerous, and how a vaccine can help. And if we want to reduce constraints, we have to make vaccination easy. We have to make walk-in access, for example. If we want to increase calculation, we have to open a discussion with the people. We have to allow an open weighting of costs and benefits, and we have to tell people what is the good and what is the bad side. We have to be open about it. If we want to increase collective responsibility, we should not talk about the piggyback riding. We should rather encourage that herd immunity helps, and that there's always people who cannot piggyback ride, or who need to piggyback ride because they cannot vaccinate themselves. Sorry. If we want to increase compliance, we have to be flexible with regulations. We have to adapt our systems and regulations to the current situation of a pandemic. We don't have to over-regulate, because then people who like anarchy will get mad. But we need it when things are bad. And finally, for conspiracy, of course, like the autism conspiracy that still exists, we just need very active debunking. That was from my side. Thank you very much again for all the presentations. It was very insightful and wonderful seminar. Thank you.
Thank you very much, Mattis. I have to say, I loved working with you. I think we managed within 20 minutes to wrap up and let people go for lunch. I hope everybody enjoyed our quick and dirty research on the go. That's what we did. We all mapped our perceptions, and we had Mattis write the discussion section of the paper for us. I'm sure there was a lot more points to discuss, but I'm afraid, Mattis, we would have to part ways now, as our lunch is waiting outside. But it was great having you on board today.
Thank you very much. Thank you very much.
And of course, expect an email from the internal team to discuss more about what we did.
I will. Thank you very much.
Thank you very much.
Have a good weekend. Bye.
You too. Okay, I think we can go for lunch. We really apologize for being so late. Nothing more to say.